Good morning, esteemed delegates. After the grand success of day one of the conclave, I am privileged to welcome you all to the first session on day two of Patient Safety Conclave 2026 with the theme Understanding Errors in Healthcare and Building a Culture of Safety, organized by Era University, Lucknow in association with Academy of Health Professions Educators, AHPE. We are honored to be joined by distinguished dignitaries, academicians and scholars who have graced this occasion with their presence. Before starting the session, we are going to have a recap of day one proceedings, and for that I want to briefly tell you about Professor Dr. Priscilla Sampson. She is Principal, Era College of Nursing, Era University, Lucknow. She is a coordinator to Divine Project, Diakonia University, Finland, which was co-funded by Erasmus European Union. She was in the panel of competency-based curriculum for PAHS Nepal. She is a simulation trainer affiliated by Indian Nursing Council. She is also the chairperson of College Research Committee, a member of IRC and PAHS, member Health Professions Education, advisory board member of Indian Journal of Continuing Education, and core committee member of CNPD USMF. It is worth mentioning that she is a recipient of notable awards such as Foundation of Leadership Award and National Society of Leadership and Success in United States of America. She has published 35 research papers. Ma'am, please grace the dais.
A very good morning and welcome to all. So I've just briefly brought you the highlights. I think we all had a very enriching, those who were present yesterday, we had a very enriching day of learning and, with shared experience that people, really experienced people were here. So I'll just start with so we have already heard what the theme is, understanding errors in healthcare and building a culture of safety. I'll just take you through from inaugural ceremony that we have. Our chief guest was Professor 𝐂𝐨𝐧𝐬 and guest of honor Dr. 𝐒𝐚𝐿. And there was a release of patient safety flyers and souvenir by the chief guest and the guest of honor. And the key message for all this for this ceremony was patient safety is a shared responsibility requiring leadership, commitment, and systemic reform. So we had a wonderful time during inaugural, and we got to hear such dignitaries who were really expert in the area of patient safety. These were a few glimpses. Now we had some keynote addresses. There were two keynote addresses. First was the genesis of patient safety, and second was prescribing skills and patient safety. And the focus area of the keynote addresses were evolution of patient safety movement, rational prescribing practices, reducing preventable medication harm. We had also scientific sessions and understanding medical errors. The fundamental were taken by Dr. Vinas Supe, policy and regulatory framework by Dr. 𝐒𝐚𝐿. Advanced patient safety through digital health innovation by Mr. 𝐂𝐨𝐧𝐜 Khan, and implementing change from research to policy and practice by Dr. Beena Joshi. Panel discussion, the theme was case studies and learning from errors. Those who were present, you can really say that the expertise in this area from different areas who presented diagnostic errors, ICU medication errors, surgical never events, and medication errors, they brought up some very good experience, their own areas experience, their own practice experience, which was very enriching for all of us. The top takeaways from day one were almost 1 in 10 patients is harmed globally, which is very alarming. Patient safety is the third leading cause of death. Safety is mandatory, not a choice, but a priority. Build a no-blame safety culture. We heard again and again in yesterday's sessions, and many of them emphasized that no-blame safety culture. Unless we don't have that, we are not going to succeed in what we are looking for. And psychological safety is another one, creating an environment where healthcare workers can report errors without fear. So we need to build a system as such that, and one speaker also said that there should be a reward system if somebody is coming and reporting their error. Key safety measures were attention, observation, decision making, and time. AI reduces cognitive overload. We also heard a lot about AI and how digital systems can help us, to prevent these errors. And they create healthier workflows and enhances patient safety. And of course, the cognitive overload that Mr. 𝐂𝐨𝐧𝐜 Khan also gave us, exercise to do. And health technology assessment shift from empirical practice toward evidence-based decision making. So these were the certain key points that, and I will end my presentation with this very good note by Florence Nightingale. And she wrote this in 1864, where she said that very first requirement in a hospital is that it should do the sick no harm. With this thought in mind, we continue to our day 2 presentations. Thank you very much.
Thank you, ma'am. Now I would like to tell about the 2 eminent chairpersons of the first talk of this session. First chairperson is Professor Dr. 𝐾𝐚𝐭𝐢𝐞𝐧𝐭. He is the Chief Medical Superintendent at T.S. Mishra Medical College and Hospital, Lucknow. He is also a member of the governing body of the T.S. Mishra University, with a background as a former Pro-Vice Chancellor at King George's Medical University. He is a key administrative figure at TSM Medical College. Sir has a teaching experience of decades, and he has published numerous papers in national and international journals. Sir, we are honored to have you. Please raise the dais. The other chairperson for this session is Professor Dr. Anuja Bhargav. She is the head department of ENT, Era's Lucknow Medical College and Hospital. She is an MBBS gold medalist. She is Assistant Registrar Academics, Clinical Skills Lab in charge, and also the IPE Ambassador of Era University. Her achievements include MAHE Famer, RFA CMCL Famer. She is a certified healthcare simulator by the Society of Simulation and Healthcare USA, a member of National Team Standard Treatment Workflow in ENT. Her notable award include Best Paper Presentation at ICON IPEPC 2021 and 2023. She has more than 25 publications or chapters in national and international publications. She is also a co-author of the book Clinical and Procedural Skills, a Step-by-Step Approach. Ma'am, we are privileged to have you as the chairperson. Over to you, ma'am.
Good morning to all of you. Firstly, I must with this opportunity to chair this important session. And as Patient Safety Conclave, its name, patient safety is very, very important for all the persons involved in patient care, especially for doctors. You are budding doctors, most of the new faces here sitting. You must be very careful while handling the patient and patient safety, because in court of law, though everybody involved in the patient care is responsible, but in court of law only doctors are involved. So doctors' responsibility is more than anybody else. With these words, I must introduce my today's speaker, Professor MMA Faridi. He is the Dean, Faculty of Medicine, Era Medical College and Era University. His achievements are over 43 years of teaching experience in pediatric. He is famous pediatrician from this city. Originally, I have met him in GTB, I think. Around 10 years back, 15 years back, he was heading the department there. Superintendent, Director, Professor and Head Department of Pediatrics, UCMS Delhi. Facilitated as Legend of Delhi by Delhi State Indian Pediatric Association. Key positions held by him are Director, Professor and Head Department of Pediatrics, UCMS Delhi. Visiting Professor BP Karala, American University of Barbados, and and the Jain State Medical University. There are so many awards, fellowships, so I don't want to waste much time and invite Professor Faridi to deliver his lecture.
Good morning, friends. My very dear friend, Dr. G.P. Singh, Dr. Garg, Dr. Dandika, thank you very much for inviting me, and sir, thank you very much for elaborate introduction, to which I don't think actually they might have used some AI to make it so laborious, I don't know. But yes, thank you so much for, and I'm really indebted to Dr. Dandekar to giving me this last minute assignment, which is very dear to me. And the topic is also, I request all of you, just look at a culture of safety. My talk would be just to recollect some of the what had all been discussed yesterday, to set the board to talk about, but this developing a culture of patient safety is simply to say is very difficult to implement. And this is everywhere, including whether it's in Delhi or which is in 𝐿𝐴𝐺𝐕𝐄, Lucknow, or any other place, or you'll find n number of resident doctors with sleepers and the headgear, OT sleepers outside, ICU sleepers out. They're roaming around, have a cup of tea, and they go back. And so also the other allied health sciences people working, and it becomes a kind of a status symbol that you are having a shoe cover and a head cover, and then you're roaming around. Many times, since I always tell them to do like this, many times I roam around many times in the hospital, so they just take a patli gali and they go away, so that Dr. Faridi may not come and confront them. So I accepted that in spite of having this topic very dear to me, and have worked in a reasonably administrative positions where the students listen, but I'm not able to inculcate the culture of maintaining the safety. So with this, my failure on this part, so that maybe that might inspire my young colleagues here, and they might go for that. So let's see what is patient safety. You have heard a lot yesterday, so it will be just recollection and putting the things across. The most basic definition for safety is putting an end to avoidable errors and negative practices suffered by patients within the healthcare settings. We generally talk about infection, or at best we say there may not be any physical injury. NABH looks at all these aspects. Our hospital, fortunately, is accredited by NABH, so many of the things are at place. You must, many of those who are working here is a code blue, code red, code, all those are already there in place. But the issue of patient safety has become more complex now with the new technology. Treatments and the medicines. Robot you are hearing every time. Robotic surgery said to be a panacea for all kind of surgeries, And we know that those who are operating robots, they are not trained during their training. And hardly maybe some observation for a few weeks or at some place, or maybe 2 months, 3 months exposure, maybe hands-on, and they call them robotic surgeon. It is important to understand that. New technology to imbibe and to use with perfection. You can understand, I won't go into the nitty-gritties of that, but that's actually making the things difficult. मोबाइल अभी भी जितने लोग बैठे हैं, काफ़ी लोगों की नज़र अभी भी मोबाइल पे है. कुछ वो हट गए ये सुनने के बाद, मैडम मुस्कुरा रही हैं. ये भी एक हमारे पास ये पेशेंट सेफ्टी पे बहुत बड़ा असर है इसका. अब प्लीज़ एक बात और समझ लीजिए कि पेशेंट सेफ्टी नॉट जस्ट फिजिकल, mental agony is also a part of the safety. I have got a patient right now under Dr. Salim is sitting here, and another patient, I don't know if orthopedics person is here or not, he's a very bad infected lower limb after a surgery being done in a teaching government hospital in North India, and is a very bad shape. And they just said, amputation kar do. See the amount of injury to the family, to him himself. His wife was crying yesterday. All this actually come under the patient safety issues. Nobody talked to him. Patient wants to talk, remember. They want to talk. उनसे दो शब्द बोल लिए जाए. Yesterday you saw a kind of presentation about how to talk communication. Although the second one also was not proper, but shared better than what the first lady was talking to the patient. Counseling is a different story altogether, and we don't do it. Just see the effect of counseling. If I ask somebody to say, please close the door, same thing I say, will you please close the door? It makes all the difference. So this language we never, in our day-to-day, we never speak like this. So that's the beauty. This also actually adds to the injuries. If the patient is not following our advice, that's also actually compounding the injury. That is because of the poor communication. क्यों चल क्यों नहीं रही है? क्यों आगे क्यों नहीं बढ़ा भाई? Now let's see some of the factors the patient harm. Remember that I'm not going to tell about what are the facets of patient harm. I'm still concentrating myself the culture of safety to inbuilt. Let's see where is actually things happening. So system and organizational factors. I do agree that there could be staffing issues. Inadequate staff, large number of patients coming to, that many patients not coming to ERA. But go to KGMC, OPD 10,000, 15,000 OPD. I imagine yes, this can affect the way you are handling the patients. But then it's not everywhere, not in every OPD, not in every case. So there are system organization factors which may be responsible for ultimately indirectly be increasing the patient harm. Technological factors I already said. Then health information system. Yesterday we heard about the ICU things. 𝐒𝐴𝐺PJ is not using electronic patient data. So it's good to have the data, but remember that managing it is not so easy. I'm sure everybody knows about what happened 2 years ago in AIMS. Entire data was hacked. So even on the late Prime Minister Indira Gandhi's samples was also, the data was also stolen. So preserving and protecting the data becomes a very, very important issue. And you can't share my personal even phone number with anybody else. And that's what when it comes to Meta and WhatsApp is under tremendous pressure by the government of India that you can't share. Human factor will be extremely important. Communication breakdown of my healthcare workers, every day is issue in our place. Every day. In ERA, and I'm sure this happens everywhere. ये patient हमारा नहीं है. ये patient तो. And there's constant fight between respective department and medicine in our place. Primary कौन बनेगा? Because we evaluate every death. So the resident have to prepare the presentation. So the primary team presents, तो हम नहीं बनेंगे primary team. What is happening? Communication breakdown is a very, very important issue, and that actually prolongs the admission. नहीं हो रहा, fluid delay हो गया. So 2 hours delay. Patient came here because we are on electronic data. Patient reported here at say 11:30, and ultimately admitted in a primary team at 2 o'clock. What happened with this? Nobody is actually treating. Fluid लगा दिया, finish oxygen लगा दी, बात खत्म हो गई. कौन देखेगा? All these are actually the compounding the effect. We are fortunate that we are not sued for everything. हम problem में आते हैं when the patient dies, unfortunately. Rest of us we are not. But lot more patient safety issues we are concerned with. So please look at it. We have made a system that if nobody is admitting the patient, let the emergency team admit. We have the emergency department, and later on it will be transferred to. So there are issues, and one of very important, not only here, it's everywhere, I'm telling you. Then patient-related factors. limited literacy, lack of engagement and non-adherence of treatment. That's a very, very important issue in why we have red dots directly observed. But what is happening? We have got a large number of work we are doing on prevention of tuberculosis in children here in Era, and we are a part of the consortium of prevention of tuberculosis in children at Boston University. Some of our data is with them, of course, with the permission of for a purely academic purpose. And that has been now presented to Lancet very recent. In a few months' time, we'll see the data there. What I'm trying to convey to you that the adherence to the treatment is fundamentally because of that we were not able to actually inculcate in them, sensitize them that this is important. And there's adding to which is not visible. This is a patient safety issue. If they don't take the medicine properly, our Honorable Prime Minister's vision was to eliminate tuberculosis by 2025, but because of the COVID, we couldn't do that. Now it's at 2030. By the WHO at 2027. 27 is just knocking, and we are nowhere. So this is, again, a very important issue in patient safety. These have been said very well. Medication safety, we have talked a lot about it. People say 6 right. I'm sure Dr. Sampson is here. So I was told one of the PG student of your that there are 12 rights. The nurse has a right. She knows that the treatment generally given for 7 days. It's already 7 days now. It's today 8 days. Should I give the medicine or not? So she can withhold and talk to the doctor. And here I think the doctor will be very uneasy and be very angry. Treatment hum kar rahe hain, doctor tum ho ke hum karenge. But this is the patient right. The patient should not be harmed. A usual treatment 7 to 10 days, already 10 days over, should we give it or not? So this is a very, very important part of medication safety, which we are not talking about. We are not empowering the nurses or technicians for that matter. But this is a hidden part, and that actually comes under the culture of safety. Understand what actually the safety is. Surgical safety again. 100% accuracy patient identification across all care transitions. And this is still not happening. Even in our own name, one of our doctors here operated in dental surgery department, sir, in our own institution. सिद्धार्थ बैठे हुए हैं, लेफ्ट की जगह राइट का टूथ निकाल दिया जो ठीक था उसका. अभी हुआ है कुछ दिन पहले. So this is not uncommon to have it. Please accept it. Accept it. This is happening, and be careful about it. We are being invited. India AI Summit is happening in Delhi from 16th to 20th. And the government of India has invited Era Medical College to present what they are doing for prevention of errors. So we'll be there for 5 days. Chancellor Saab is going, and so also the additional director of administration is going, and I'll also be there. So there is a need. There is a need to have it. Understand that still the things are happening. So another important thing come up is IoT, the internet, other things. Things are actually happening. RFID, this also be developed. We also developed a few things we won't disclose here, but some of the things we are also developing for prevention of retaining of the instrument during surgery. So then see, what else we need? Healthcare associated infections, sepsis, blood stream infections, central lines, diagnosis errors, all this actually becomes the DVT, venous thromboembolism, unsafe transfusions. I didn't hear anybody talking about the blood bank, the maintenance, which is a source even today happening. Actually, that patient who has come here after the surgery, which was admitted orthopedic department, also found hepatitis B positive. And hepatitis B doesn't come from orophycal route. It actually comes from, and he was giving 3 transfusions. We don't know what actually happened. So this is a very, very important issue of transfusion safety is an issue. Unsafe injection practices is still going on. In spite of having the auto-disable syringes, things are still happening. And many times they still recap when they're throwing it. See, they're making themselves vulnerable too. And then patient falls. Of course, this is also one of the important issue to be taking up. Technology integration and future safety measures are important. Digital technologies are important, electronic health records important, but at the same time, remember the machine learning we are using. We are using machine learning for maintaining whether posturing is being maintained or not. We had a very, very small incidence of back problems occurring or bed sores occurring in our hospital. So all these machine learning part all ultimately going to, but then remember that operating these machines and systems itself create a lot of problems. That's important. Then system approach to patient safety, ensuring leadership commitment to safety and creation of a culture whereby safety is prioritized. So actually that has to be inculcated, developed. It's a response. I appeal to all the faculty members sitting here and all the senior residents and GR3, please inculcate this, make it your responsibility. Because patient responsibility is our responsibility. Or this also the nurses. They should not allow. They should not allow if the person, your child लेने चले आओ उसी को पहन के बाहर जाके ले आता है चाय. Don't allow them to go out. Change it. Change the your sleepers and go. What we have done, many hospitals have done in Delhi, उसमें कट कर देते हैं जो OT के inside की है. तो कुछ सिस्टम ऐसा हो जैसे कब से पकड़ तो आए कि तुम ऐसे कर क्या रहे हो, and let them say don't do that again. Then this is what the WHO came out. We are not very concerned with this. WHO has come out and I'll show you what they are actually. WHO done it for tremendous things, and I also learned something which I didn't know earlier. So they actually on 11 September 2023 came out with this information that, which I won't repeat, but in a low to middle income countries, as many as 4 in 100 people die of misuse of the care. And this ultimately is affecting, which is a very glaring. See, patient harm potentially reducing global economic growth by 0.7%. I knew that if this is the American data, American 50% mothers breastfeed in after delivery. When they're discharged, roughly 50% are on breastfeeding exclusive, but by 6 months, 70% are off the breastfeed. A study conducted in America is published in Lancet that if a mother woman can breastfeed, all women breastfeed 75% up to 6 months and 85% up to 3 months, then otitis media, diarrhea and pneumonia, $40 billion are saved just on these three conditions. We say that diarrhea is here more. No, diarrhea, there is also diarrhea is an important issue in America because of the kind of, they use a lot of cow's milk and pasteurized milk and all that causes ultimately the problems with this. क्या हुआ भाई? Light weight कहाँ गई? You are 30% there. Please keep your computer on. So, what I'm trying to convey to you that patient safety is not just the issue to saving the limb and life of the patient, but is also for the ultimately growth, ultimately economy. And this world actually revolves around economy. And since the economy has also been affected, so now they are more concerned about the. This is what the digital technologies and other technology do it. So this is what actually happens, and we have to चलो हम बात कर लेते हैं. वेलकम सर यहाँ आ जाइए. नहीं टॉक खत्म नहीं हुई है भाई, बैठ जाइए. I can go without because there's no issue, but some good slides will not be able to see. Otherwise, I can talk on this issue. कितना देर और भाई? अच्छा, ये हुआ क्या ये? अच्छा मतलब वो अपडेटेड नहीं था, मेरी बातों से हो गया अपडेट. गुड. चलिए. So sorry that this is some disruption, and this is what actually reinforces my saying that technology to be used properly, and so technology is not the answer for everything. So coming to preventative errors. बिल्कुल preventable. In fact, all the errors are preventable. The word has to change. Adverse drug reaction word has to change. It's not the adverse drug reaction. It's actually the reaction of the molecules you're using. But we intended for pain. It also sometimes some affects it can give rise to some other problems, maybe rashes and allergy. So that's not actually ADR. Actually, this is the action of the drug in some. So that the perception actually has to change what actually we are dealing with. अभी 100% पूरा नहीं हुआ. दूसरा चल सकता है तो दोबारा अपडेट करेंगे. आ गया LT4 वेलकम. अभी लगाओ उसको करो. बारिश आ गया.
हाँ नहीं
Recording in progress.
यही है सर. खोल दो उसको, बढ़ा दो उसको. खोल क्यों नहीं रहा? बढ़ा दो, फुल कर दो उसको, आगे बढ़ा दो. ठीक है आगे जाओ, टाइम भी तो निकल गया ना. So coming back to, sorry for interruption. Coming back to what actually is being done, remember that, keep in mind the culture of safety. So we have to inculcate is that this should be followed. So what the WHO proposed, two important things. One is Global Patient Safety Action Plan from 21 to 30. So 10 years plan developed across all levels of patient care. And then World Safety Day, 17 September is, I didn't know that. How many of you knew that this is I didn't know that. So when I was preparing this talk, I came out that World Patient Safety Day is celebrated all over the world on 17 September with a theme. So the theme for this year, another important thing came out was the World Safety Day to be decided in a World Health Assembly. The item number 72.16 is a very, very important aspect of the WHO itself. In a World Health Assembly decided to have this Patient Safety Day. This Safety Day is actually again reinforce and have develop a culture so that we are responsible for patient safety. अब ये बिल्कुल ही बंद हो गया, चल ही नहीं रही है, बढ़ नहीं रही है. ऐसा क्यों करता है ये? The theme for this year is safety starts from birth. So that means this year's 17 September, we're going to focus more on children, because child is not a mini adult. So right from birth up to 9 years, this is what the theme has been given to this year. This resolution, the theme is safe care for every newborn and every child. The slogan is patient safety from the start. The theme prioritizes reducing avoidable harm to children but to 9 years, as I said. Remember, the child is not a mini adult. The theme is designed to unite parents, caregivers, health workers. So, as I said in the beginning, that the communication with the family and the parents also becomes important part. They're also a stakeholder. So that the safety part actually goes beyond the premises of the boundaries of the hospital. It actually goes when the caregiver is actually looking after the discharge. That's also a very important part to look into. So these are the areas which are less appreciated. You must have had whole day yesterday were devoted to different aspects of patient safety. Some of these are not actually talked about, like patient safety by referring and transporting to health facility. Is a harrowing experience because we don't know. You go to this trauma center, Lucknow, no bed. So go to 𝐿𝐺𝐵𝐺I, not a ICU full. Then ultimately go to a private hospital. It's so too costly. After a day or two, transfer to 𝐸RA. So this again, precious time is being lost while the treatment being provided. Availability of adequate care at right time. Fighting between which especially the cases to be ultimately. So that's again less recognized. Accessibility, equality of healthcare. Source लग के आएगा तो bed मिल जाएगा. That's the issue. Let's accept it. It is there, and it came from the mouth of none of the other person, but the previous health minister of UP. He stated this when we were discussing, sir, पता नहीं क्या है, जब तक हर कोई पर्चा लिखवाने आता है, patient को देख लिया जाएगा. And this is what is actually happening. So accessibility and equality to healthcare is really important for the patient safety. The lack of active communication and counseling of the patient and the family gives a mental agony in one time, and then empowering for the caregiver for adequate care at home after discharge. That adds to, as I said, why there is a multi-drug resistance or tuberculosis happening, because treatment has not been followed at home properly. And then preserving past record. So long as, see, many times the patient, you want to know if seizure happened to a 2-year-old child, I want to know what actually happened at birth, the record is not available. When the patient is being sent to refer to other places, no data is available. We don't know what actually has been given, what treatment has been given there. So that also adds to the patient safety. These are also issues which should be taken into account while you are. So now what to do? So then education, training, reward and demand. मैंने punishment word avoid कर दिया था. So remand, reward and demand. Demand it from them. It's important. You do it 4 times, 5 times. So that also have inbuilt kind of inverted commas some punishment type of them. अरे थोड़ा देर का और रह गया यार, बंद कर दो मोबाइल को. थोड़ी देर रह गया, बस खत्म हो रहा है. So that's a very, very important part, education. Now come to education, and I to all my colleagues say that the scope of healthcare, different sets are there. Teaching institutions, standalone hospitals, medical colleges, allied health sciences. The role of a medical college is not to treat patients. Please keep in mind. I am exhausting all my faculty members here. As you see, my vice chancellor also sitting here, the principal also sitting here. Medical colleges are not meant for treating patients. Medical colleges produce doctors. Our aim is to train them how to treat a patient. That's our responsibility. And for training, not only for that period of 3 years passing degree, no, or 5 years for MBBS, no. They'll be working in the market for 50 years. So we are preparing them for 40, 50 years practice outside. So we are training them to treat a patient. When we say patient, includes family. You are not treating just one patient. You are treating the entire family. Look at what actually happens. You just go to the corridor of ICU, find the relatives are sitting there, you are walking, and they are by the side, they are taking food. See, this is what the situation is everywhere. Go to AIMS and see, entire staircase of metro station is full of patients, relatives sleeping there. No hygienic loo or washroom available for them. Women are also sitting, men are sitting. Imagine the uncomfort they are facing. We have no answer for them. Rain Basera is not the answer. GTB hospital, I was working, the 3 Rain Baseras are free. But वो answer नहीं है उसका. So what I'm trying to say, we have to, as a medical college, our responsibility inculcate in them, apart from the training them how to operate, how to do minimal surgery, how to do a culture department, also tell them that this is what an important part, how to inculcate at every step that you prevent patient, inculcate them. Why we are waiting for the report to be vetted by a capacity department faculty? Why? Because we want to prevent errors. We want to prevent problems with for the safety of the patient. Now, remember what is education. And I like to request everybody here present in this August gathering, remember that education is a process to bring about a desired change in an individual. That's education. Education is no degree. That is certification. That you possess that desired change in you. So desired change is very important. Desired change is that prevent patient safety. Look for the patient safety. That's a desired change which comes into. It has 3 domains: cognitive domain, psychomotor domain, and affective domain. In fact, the affective domain we must start thinking on it. Why we always take our patient, अगर हमारा कोई relative है कि हम head साहब को दिखाएंगे, why not to secondary PG? But the secondary PG is going to tries to see the patient. Why not the third year PG and SR? Why not the faculty? हम अपने को तो उनको दिखाएंगे. Equality तो नहीं हुई, पर equality and accessibility is a fundamental right. So look at that. The psychomotor domain, they must be told about how to do it. That's the psychomotor, your skills. And Madam said, do no harm to sick patient. Yes, do no harm to the patient. That's what is important at all levels, by all stakeholders at all times. They are non-negotiable. Examples to be set by the faculty members, health managers, and health administrators. They many times this happens. अरे सर आ जाइए, कोई बात नहीं है, यहीं तक आएंगे. नहीं, ICU में नहीं जाएंगे आप होंगे, कुछ भी हो, हेल्थ एडमिनिस्ट्रेटर है, मालिक है, MS है, हेल्थ आप हेल्थ मिनिस्टर साहब आ रहे हैं. आई डिड इन दिल्ली, मैं नहीं अलाउ करता था, आप सर ये पहनिए वो तब आप अंदर आएंगे. सो इट इज पॉसिबल, यू कैन डू इट. सो रिमेंबर दैट, सावधानी हटी और दुर्घटना घटी. ये लिखा हुआ रेलवे स्टेशन, आप जाइए वहाँ पर. सो guard lowers, mishap occurs. So you have to prevent this. This should be the slogan. The Savdani should not get up. So thank you for much, and see that patient listening. Patient is listening. He knows that. Thank you so much. And you are saying that this looks as if it's not 2 cars, it's just 1 car. Yes, life like this, it looks like it's deceptive. So life is deceptive. Please, I am really thankful to you, that time loss. I'm sorry for that. Maybe the technology reimbursed my thing that yes, it can happen. So technology also to be used properly. Thank you so much.
Thank you so much, sir. And it was an absolutely enriching session. And I think I would thank Sucheta ma'am for having this session for you to start off, because this is a prelude to the session that follows, that is teaching training for patient safety. Before we open the audience for the question, which we can allow one, Dr. Shiraz, can we have one question? Okay, so sir, there is a point that I would like to emphasize. I describe myself as an interprofessional simulationist, so I would like to share a point which has been shared by sir's points here in the lecture, and that is about just culture. But I would like to ask everybody here, which we see a lot of medicos here, people from interprofessional background, the day we enter into medical school, the first thing we are told is, boss is always right. Now with this theme, this particular fundamental that we have been told, boss is always right, we are trying to implement just culture. The second most important challenge that we have to overcome, in a team of interprofessional healthcare, the doctor is always right. So how do we implement just culture? Sir, that's my point to you. With you being at the lead of Helm of Affairs, how would you like to help us overcome these 2 challenges?
Just culture, yes. That's also inbuilt accessibility and equality and everything. It's simple. It's simple. And that is to be implemented by on yourself. It's possible, it can be done. So that's the most important thing, is that we many times dilute this aspect And so no dilution. And for that very strong conviction actually has to come, which is actually lacking in most every walk of life. So we can't separate it out, but it is doable to an extent that all the SOPs actually should be properly maintained, should be properly written. Every stakeholder must know why this is important and this is doable. I have not seen that this is confidence, so just I agree with you that this should be just, accessible, equity. And since you are a simulist, kindly arrange some lecture. We never had a lecture on patient safety. We never had the case presentation where the mother comes and says, I don't have enough milk. We never had any lecture on that. We never had a lecture that you advise 3 medicine, one to be taken at 10 o'clock at night and your child sleeps at 8 o'clock. तो मैं क्या करूँ उसको कैसे जगा के पिलाऊंगी दवा? We never actually think on these aspects because it's so simple to, we say go discharge and come on after 4 days. That after 4 days could be a holiday. We never say do that. So all these actually are issues important, again, person to person talking. So I'm happy that this issue has come and 17th September is coming. I discussed this yesterday with the Honorable Chancellor. He said we will celebrate that and this will be an annual event in Era now because we are working a lot on preventing the errors for patient safety. So this will be an added incentive for the hospital, for the college to make it a part of the curriculum and the system of this hospital.
Thank you so much, sir.
It's old saying that boss is always right. We have to come out of that mindset.
Yes.
Because boss always may not be right. But as you have said, you never lower your guards. Otherwise, accident will happen. So be always careful.
Thank you so much, sir.
Thank you.
Thank you.
Thank you, sir, for the excellent talk. We now have to present mementos to our distinguished chairpersons and speakers as a token of appreciation for their meaningful contribution to this event. I request Professor Dr. Tariq Mahmood, Head Department of Biochemistry, Ras Lucknow Medical College and Hospital, to present mementos to our honorable chairpersons, Professor Dr. 𝐏𝐚𝐭𝐢𝐞𝐧𝐭. Next, I request Professor Dr. Anuja Bhargav to please receive the memento. Ma'am, please come. Thank you, sir. Thank you, ma'am. Now I request both the chairpersons, Professor Dr. 𝐏𝐚𝐭𝐢𝐞𝐧𝐭 and Professor Dr. Anuja Bhargav, to present a memento to the speaker, Dean Sir, Professor Dr. MMA Faridi, sir. Thank you, everyone. Start. Now I would like to brief about the two honorable chairpersons of the next talk of this session. Firstly, Dr. Vimala Venkatesh, Professor and Head Department of Microbiology, King George's Medical University, Lucknow. She completed her MBBS and MD Microbiology from AFMC Pune. She is an ex-Army Medical Corps and Vice Dean Academics. She is faculty in charge, Center for Advanced Research, also a convener Nodal Center for Faculty Development Programs, National Medical Commission, and a former president of UP UK chapter IAMM. Ma'am, we are honored to have you. The other chairperson is Professor Dr. Uma Gupta. She is from Department of Obstetrics and Gynecology, Era's Lucknow Medical College and Hospital. She is the coordinator of Medical Education Unit here. She is a FAMA Fellow, a Nodal Officer, RRTC, Era's Lucknow Medical College and Hospital, faculty at UNESCO Chair of Haifa Bioethics. She has presented numerous papers in medical education, awarded Best Poster at ICME and FOXY. She has more than 90 publications in journals of national and international repute. Thank you so much, ma'am, for coming. Over to you, ma'am.
Good morning, and thank you very much the organizers, especially Dr. Sucheta, for inviting me to chair this session. It's a session that's obviously very, very close to my heart, education, and I firmly will thank you, sir, for introducing that education is at the heart of learning, right? Whatever we want people to learn, whatever we want our learners to learn, is what we have to inculcate in ourselves and then further the teaching. I will now request Professor Farzana Mehdi, Director Academics, 𝐿𝐴𝐻, Lucknow. Can I please, ma'am, request you to come for your session? Will you be putting up a CV so that I can read it? I just have the CV डालते हो?
Oh, that's all right. तो करो जो करना है.
So, ma'am.
Yeah. Thank you, ma'am.
Ma'am.
Thank you so much, ma'am. I would like to extend a very warm welcome to all of you who are sitting in the audience. And Dr. Vimla Venkatesh, madam, I'm delighted that you are here with us today. So without taking much of your time.
Ma'am, can I just introduce you?
Yeah, sure, madam. Thank you.
Because she has so many accomplishments, I feel I should read out some of them.
Thank you.
So, madam has established this college actually in 2001, made it into a university in 2016, and she has pioneered the certificate and postgraduate diploma course in health professional education with collaboration of 𝐶 International Virtual University. She has been the General Secretary of the Indian Society of Personalized Medicine, the General Secretary of Allied Health and Healthcare Professions and Education Research. She is the Organizing Secretary for the 15th National Conference on Health Professions Education, which we all attended last year. She has been awarded numerous fellowships of them. She is the Fellow of the National Academy of Medical Sciences since 2022, the Fellow of the Indian Academy of Biomedical Sciences since 2022. She has more than 150 publications in national and international journals, and she has books on precision medicine and human health, clinical and procedural skills. I wonder, she has been doing so much along with establishing a medical university, and so that is such a big job. A big round of applause for Madam, please.
Thank you, madam, for your very kind words. So, as you all know that this conclave is going on, and I'm sure that it's going to be one of the landmarks in the area of patient safety. I am really very honored, and I feel blessed that since yesterday we have had a number of very, very distinguished speakers who all are at the peak of their career, and they are really busy. but they all took time to come, some even for half day and just for few hours, 12 to 14 hours. And as we had NCHP also dedicated for patient safety, and this conference, after this, we will be coming out with a white paper Professor Sucheta and her team is going to put together, so that what all we have discussed and learned, it should be known to each and everyone whosoever is connected with this field. So with these thoughts in our mind, we tried to organize this conclave. And since yesterday we have all been listening to the importance of patient safety and its various aspects. But something which is important is that if you have to build this community of practice, this kind of a setting where the patients are safe and all of us as health professionals do our needful in a moral and ethical way, then we need to develop our students, teach our students, UG, PG, whether it is these are medical people or these are other health professionals like nursing, paramedical, pharmacy, technical staff, and so on and so forth. So for that thing to come in place, it is important that while they are getting their degree, along that path, at every step, in each of the department, each of the faculty, we need to tell them what are the important features or things to be done in order to ensure that the patient is safe. And in order to minimize the errors, they should be made aware beforehand. So in this area, I would say I'm very privileged, and I really thank my former faculty, GSMC. Madam Sucheta is one of my mentor. That in the year 2013, I got this opportunity of doing this FAMER fellowship from GSMC Mumbai, and there I had taken up the project of starting a clinical skills lab and trying to implement the clinical skills teaching and training into the curriculum of the MBBS students. So starting from there, up till now, what we have done, we have tried to, and this thought came to me because at that time, and still it is going on, we are seeing that there are so many errors happening at every step. So one person will not be able to bring about the change, but at least that thought and one action can lead to a chain of changes which can be brought about. And we have seen a huge change in our own setting and some of the other medical colleges to whom we had offered our services. So we set up a lab, clinical skills lab, with minimum resources and tried to teach and train the students. And during this more than 10 years of our work, we have come out with a book which is having all the clinical skills, and the modules are there. They are describing how those skills can be carried on, and along with a checklist. So with this, we think that we have tried to train our health professionals. So with this brief introduction, I would just like to take you through few slides, and then later on, Madam Sucheta and Anuja are going to tell you that exactly how should we go about in incorporating patient safety measures into the curriculum, so that a graduate, once he has graduated, he will have some sense to make minimum errors. So we begin with the video. Please enjoy the video, and then I'll be talking about it. Okay, that's fine. So here, as you all must have seen, this is just an overview as to what a patient goes through when he has to be, admitted in a hospital. And along with the digital technology, the use, how things are being made, simpler for all the healthcare teams. So the topic is education and training for patient safety. These are some of the keywords you must have come across yesterday. So, can we move on? So the patient safety imperative, the WHO vision. So patient safety, as you all have been knowing, the absence of preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. So global action on patient safety was adopted in May 2019, which emphasizes on patient safety as a key strategic priority. So every year for last few years, we have seen that World Patient Safety Days has been observed annually on 17th of September, and all the medical colleges, they organize various programs to sensitize their faculty and students. So what is the this global patient safety action plan starting from year 2021 to 2030? And what does it say? It says that the goal is to achieve the maximum possible reduction in avoidable harm due to unsafe health care globally, envisioning a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time and everywhere. So this is a decade of patient safety under the flagship of WHO initiative. So what is there in this plan? We are trying to aims to eliminate avoidable harm in healthcare. The cornerstone is systems approach. Those all who are present yesterday, they'll be aware of what is a systems approach and how important it is in the patient safety. Acknowledging human fallibility, but emphasizing error catching. We are focused on technical as well as non-technical skills. So, you have to support patient safety education by creating curriculum resources to facilitate safe practice in workplace. You have to come out with a curriculum guide that can be easily adapted, empower healthcare schools and universities for capacity building, raise awareness and engage commitment. So these are some of the common sources of patient harm, like medication errors, surgical errors, healthcare associated infections, sepsis, patient falls, unsafe injection practice, patient misidentification, unsafe transfusion practices, pressure ulcers, venous thrombolism, embolism, diagnostic errors. So why I'm trying to again emphasize on this, because all our interns are here with us today, and I want that if they are attending the session, all these things should go through their minds. So what are the factors which are leading to patient harm? System and organizational factors is one of the key reasons. Also, with the use of technology, there can be technological factors as well, which needs to be taken into account now. Not only should we be told about the technology which is going to help us, we should also be aware as to when, why this same technology, if not being used properly, can harm us. That is a very important factor. And of course, there are human factors and behaviors, patient-related factors, and there can be other external factors also. So coming to the curriculum reforms, now I would want to invite Professor Sucheta. She will be with all of you to take you through this journey.
Welcome, Dr. Sucheta. It's my privilege to be here. I'm opportunity to introduce you. She is professor in biochemistry and also medical education. She has numerous achievements and awards to her. Recipient of 𝐂𝐨𝐧𝐜 College 𝐾EM Oration Award, Best Teacher Award from MUHS, Lifetime Association in Biochemist Rita Sood Award, Lifetime Achievement of Famer Fellowship. Then she is a MHP from Keele University, a global faculty of Famer Institutes, and lots more.
Yeah.
I'll not waste, and she has many publications, more than 120.
I think by now everyone knows me. Thank you so much. And moving on to what we were talking about, the curricular reforms. Since all of us here are here together, whenever any part of a curriculum or any module has to be introduced, it needs to be done in a very systematic way. And for that systematic way, for anything to be inculcated in a systematic way, there are frameworks that are available. And each framework has a story to tell. Anything that has to be done in a proper sequence and in a way. And that is why when we introduce a curriculum, we use what is known as the 𝐾𝐚's framework. Next slide, please. Oh, I can do that, yeah. So this is a 6-step process by which we can use it. I'm sure most of the medical educationists here are aware of it, but I thought that even the bachas here and the not so much bachas, because I don't think many of you would like me to call you the bachas, but for us, you are so. You should know what goes into making this entire curriculum. Something that वो paper में आप देखते हो, website पे देखते हो, NMC का document है, allied health का document है, वो कैसे पैदा हुआ? It just didn't come out from the, just because one person felt कि ये ऐसे करना चाहिए, इसलिए हमने कर दिया. It was not the whim and fancy of one person. It is a whole group of experts and people who sit together and they say, what is the need of the hour for today? And that is why you will notice that 1900 से जो curriculum शुरू हुआ था, that slowly underwent a change. And now we have gone into what is known as the competency-based curriculum. And all of you must have seen this on the website also. And not only the medical forces, the competency-based medical curriculum, but we also have the allied curriculum also in place. Physiotherapy, all the bodies are now putting them together. So how did we do it? We did it by using this 𝐾𝐚's 6-step approach, where first we identified that we need a curriculum change. दुनिया बदल रही है, IT आया है, digitalization हो गया. There's so many things that have changed. And when that changes, we need to be abreast with the people and with the situation that we are in. And that is why we first identify the problem and have a general needs assessment. So using surveys, etc., we will send it to all the experts saying, what is it that you think need a change? So we will not only just ask the experts, we will ask our students also. People who have gone, all of you will be asked at some point of the time or the other, that what is it that you felt was lacking? What is the lacuna? And you tell us, कि madam ये हमको पढ़ाया ही नहीं गया. Only when we became an intern, we realized okay, this is such a serious thing, and we didn't even know we had to, tackle it. So that is when we need to have the needs assessment. So people, everyone, even the lawyers are brought into the fore for this, because they will tell you that when there are court cases, what is it that people are trying to identify and what are they saying what went wrong. And that is when the needs assessment is done with a whole lot of people. Even when the CBE curriculum was put, the NMC and all the bodies will put it into what is known as the public domain. And in that public domain, they will say, this is now open for discussion. So it is people like all of us who should rise to the occasion and write. If you think anything is wrong, use this chance to make your voice heard. Because you will say, "Arey, ye kya ho gaya? Ye to kitna kharab hai? Ye to we never thought of this. Why did this come through?" But you were given a chance to talk. You were given a chance to speak. Why didn't you do it? All right? At least it has to be voiced. So that is the needs assessment. And then, of course, we have a targeted need assessment as that part too. After that is done, there are the goals and objectives that are set out about the curriculum, along with when you have a goal, how do you take it forward? So there will have to be educational strategies. How will you teach it? Will you have a skill? Will you have just a lecture or what? And then ultimately there will be a evaluation of the whole process. So this in brief, I just wanted to tell you how it goes about. And as I said, the NMC has this document where all of you have also gone through it, and as teachers, we have developed all this for you. That's the ATCOM module, the skill training, the early clinical exposure, and the assessment. So knowing all this, and knowing that all this is in place, what we did was, we have taken the WHO listed topics as the guide. WHO says that all this should be ideally included in the curriculum. These are the 11 topics that have to be ideally ingrained into your curriculum. We are not saying that, all of you may be saying, "Arey baap re, aur ek kuch padhayenge." We will have our curriculum overload. ना हर एक बच्चे के दिमाग में ये आ गया ना, अभी और क्या पढ़ेंगे? But rest assured, what we plan to do is, we plan to just ghusaw it into your everyday teaching. All right? So we are not going to say, abhi ye module hai, and this is what you have to do. We're not going to do that. Gently we are going to include it into your curriculum so that you don't even know that it happened. And it is not an additional burden on you. So that there is no curriculum-itis that will happen. So these are the topics. What is patient safety? I'm sure you'll be able to read this. I'm not going to spend time reading every line there. But using this, what I did was, I used a little bit of the AI, and I asked ChatGPT to give me a visual curriculum map on the WHO safety topics across the MBBS. And I'm sure Dr. Pragnesh will tell you this later, that if you use a good prompt, then AI also can be used, very judiciously, and something that will help us. Of course, you have to apply your mind also to everything to see whether AI has said things properly or not. I mean, we will not, rest assured, it's not something that we will copy blindly, but at least what we got in using AI was a framework which could tell us exactly which topics could be integrated into at what level of MBBS teaching. So this is the only part where we used AI to tell us that this is what we can do as far as the topics are concerned. So at every level of first year, second year, third year, fourth year, and the internship, we will ingrain these topics. And this is then what I sat and worked out, saying, what is it that can be used? you know. So at the first year level, all that we need is awareness. At the second year level, we need awareness which moves to application. And at the third year level, because you're already in the wards and you're already in, seeing patients, there will be the absolute application. So we have our head of medicine here, and he's looking intently to see now what all will I have to apply. So that is the application. And at year 4, there will be the accountability. You all will be, and we all will understand how to be accountable as far as patient care is concerned. And these are the subjects. How will we integrate it with the NMC competencies is put, and of course, how will you be assessed? Remember, learning happens only when there's a little bit of assessment. And we're not saying that, we say in our jargon that assessment drives learning. How many of you look at last year's paper and say, "Abhi last year ye pucha na, shayad ye saal nahi puchenge." Or, "Arey ye to लगातार 6 साल यही question आ गया है." इसलिए we are definitely going to be asked this question again. Seems that this is very important. See, everyone is nodding here. So there is a trend that everyone looks at when it comes to assessment. So we hope that we will also be able to add that certain trend so that ultimately we have the patient comfort in our minds. And that is what we hope we will be able to do. So this is the WHO Safety Curriculum Guide for medical schools, and we will also change it for all the other professionals. So with that, I hand over to Anuja for the road ahead.
Welcome, Dr. Anuja. Dr. Anuja is Professor and Head Department of ENT, Assistant Registrar Academics. इनका ये change भी कर दीजिए इधर. Skill Lab in charge, Interprofessional Communication Ambassador for our university. She is a gold medalist. She is a certified healthcare simulator by Society of American Health Society. And she has many more clouds to her. She holds key position in the college in a number of ways which I don't want to read. And come on, Anuja, start, sir.
Thank you so much, ma'am. And a very good afternoon, ladies and gentlemen. Before I start talking to all of you, I will take the liberty to ask Dr. Shiraz, how many minutes do I have left? Thank you so much. I don't think the audience feels that. Okay, so ladies and gentlemen, I open the house to everybody. I borrow a minute before we start the slides. We saw the video shared by our Honorable Pro Vice Chancellor. I want one of you to just take the mic and say, what did you notice about it? Starting with that, I think Vaibhav sir. Sir, did you see the video? Were you there at that time? Sir, a point from you directly. What did you notice in the video which kind of stuck on to you? Can somebody hand over a mic to Vaibhav sir, please? I would like request some attention from the young attendees. It is something that I want to share with everybody.
I think the video was about a person meeting with an accident and
right, sir?
An ambulance reaching there immediately and then
right,
transferring
sir?
him to the hospital.
Thank you so much, sir. Can you just pass the mic to the oral maxillofacial surgeon in front of you, Dr. Siddharth? Because it's about trauma.
I think the patient was shifted to medical emergency department and
right,
he was dealt with, but I think the teamwork was not appropriate, what I feel.
Thank you so much, sir. We will improve upon it. But I think all of us will agree. Sir, our principal wants to add something, please. Please, sir.
The basic thing is that the person who was driving the scooter was not wearing the helmet.
Thank you, sir. That is from a community medicine leader. Please, a loud round of applause. That is so important. Thank you. Sir, now we understand why you lead us. Thank you so much on that. So, ladies and gentlemen, I would like to put forward, when we see something like this, I think most of us will agree, what is your first first flight response? Mine is to run away. Anybody else? We were doing in the past. Do you run away? Would you like to stop? Can you raise hands? The next time you see a road traffic accident, I'm talking to the interns, the postgraduates, would you like to stop, give health care, or run away? Because there is no aim of patient safety unless we understand our responsibility. Okay, how many of us will run away? Please, okay, we'll all stop. Okay, so the message is right across. Next time you see somebody, please stop to help. Okay, with this we move forward to the road ahead. And I have already mentioned, I am an interprofessional simulationist, ladies and gentlemen. Can we help me change my slide, please? From that side. Okay, so I would like to bring 4 concepts here. We have a lot of people, lot of dignitaries from other professions that I see in the audience. Ladies and gentlemen, interprofessional education is the need of the hour. And with the president of the Health Association Society sitting with us here, Madam Sucheta, we would like to please request Madam to put this to the National Medical Council, the need of incorporating interprofessional care into the curriculum. Please, Madam. We've been doing it for years. Madam is my mentor, very close. 4 points that we put across in each and every conference. Interprofessional, ladies and gentlemen, is one word, and that is the ethos of interprofessional education. Roles and responsibilities, 1. Teamwork, 2. Communication, 3. And 4, ethics. But to impart interprofessional education, you need a vehicle. You need a medium, as Madam Sucheta said. You need an educational strategy. And the strategy best adopted all over the world is simulation. I don't want to scare you off taking you to the skills lab. It's not about the skills lab at all. You can impart simulation-based education in the wonderful demonstration room given to us by our management. So while this talks about this, it talks about a wonderful word. So we'll be focusing on 2 things: imparting health profession education via interprofessional education using the fundamentals of simulation-based education. If you ask me the soul of simulation, to me it's my guru, my mentor, Dr. Professor Farzana Mehndi, who is my friend, philosopher, and guide, who to me personifies just culture. To be able to enter her room and tell her, ma'am, I've made a mistake. And I've done that number of times over the last 20 years that I've been with her. She gave me the courage to tell her whatever mistakes I made. And that is the culture we want to have in every OPD of this hospital. That is what Era University stands for. Why I need to bring this up is, we're talking about psychological safety. Where do you feel safe? Well, some of us will say we feel safe in the bathroom. That's true. Nobody's watching you. That's true. You need to have this psychological safety not only in the bathroom, not only in your houses, but within your hospital, within the chamber of your head of department, within the chamber of your principal, within the chamber of your Honorable Vice Chancellor, ma'am, within the chamber of our Honorable Vice Chancellor, sir. And I truly believe that each of us has. The next time you make a mistake, please remember there is nobody here to judge you. We can make mistakes, but the only way to learn from mistakes is to be able to identify the mistakes. So that is the concept of psychological safety. We were taught and brought up in an environment in medical schools where I just said, boss is always right. Ragging hona bahut zaruri hai. That's when you make medical fathers and medical mothers, and then the culture of fear sets into you. Next time you do something, hide, nahi to ragging ho jayegi. That's from first year. Abhi bula lenge, line lag jayegi, namaskar doctor sahab, and that's when it has started. But now we have overcome that. We don't believe in ragging at all. We believe in a relationship of mentor and mentee. We have moved away, ladies and gentlemen. Okay. Now, these are some, I would skip this slide. Now, I've already talked about psychological safety. So this particular concept of psychological safety, safe learning environment, came to the, I think, the minds of the experts. And they decided to give us something more than a demonstration room. And that's when we got a skills lab, where you can go and perform a skill with your mentor having to watch you, give you the inputs, the feedback, and you being allowed to improve. But remember, it's very important for you to do something which has not been brought into the Indian textbooks as of now, and that is called suspension of disbelief. I've seen a very strange culture. I want to share this with my mentor, Dr. Farzana ma'am. Ma'am, I've had a lot of students coming and telling me, when I've seen them giving certain injections, they come and tell me, ma'am, hoga kya? Hai to mannequin. Now we are faced with another challenge of having imparted simulation-based education since 2019, or even from way behind with the way ma'am held my hand in 2013. And after a decade of 12 years, the student is telling us, hoga kya? Ye to mannequin hai. That means we have shifted. We have shifted their frame even a step further. Instead of developing any kind of empathy, we have gone down. We need to identify this lapse and give them a sense of realism. Friends, realism doesn't come from expensive mannequins. Realism comes from creating the environment in which you expect yourself to practice. It could be with the use of a mannequin, with mileage, with environment. Every time you go to have dinner, when you come back, it's more about but you like the ambience or the food? This I open and, is the food more important or the ambience? Both. But I think if you have to choose with it, food is very important. And I think to this Gen Z, ladies and gentlemen, it's the ambience. If you ask your kids or your niece and nephews, they'll say ambience is very important. They'll probably say good. It really is. I think that's something. So my residents teach me a lot of new words. One of them is, of course, being overwhelmed. That is a new Gen Z word I've learned. So when I talk to them in the skill lab, I'll be coming to the debriefing. They tell me, we are overwhelmed. Overwhelmed with curriculum. Overwhelmed with CBE. Madam Sucheta ma'am, this is on to you. The Gen Z is overwhelmed now, and how do we expect healthcare professionals to be imparting us patient safety? Well, I fear a lot not to reach the casualty with overwhelmed healthcare professionals. Okay, so this is one of the concepts which we will be doing, which we do. The first thing that you do, this is described as level of SIM zones, level 1 to 3. In your respective curriculums, with Madam Priscilla here, with a lot of people from Allied, Rawat Sahab here, we have Vaibhav sir here, imparting within your curriculum, you start imparting the skills. And you start with part mannequins. It could be IM, it could be IV, it could be lumbar puncture. I'm not talking about a scenario here. The SIM zone 2 is when you impart it with a scenario. That comes when they're entering into final year, which they are coming. You as subject matter experts give us a scenario. We as simulationists give you the space, give you the resources, let you formulate the learning objectives and impart the simulation-based learning. And then comes the zone level 3, where they will be doing this in an interprofessional group. And this area that we identify is the most important part of the training, and that's why we have the interns in the audience. It's this time that you learn to perform the skill in an interprofessional group. Next slide, please. Okay, next slide. Okay, so this is debriefing. Debriefing all over the world. If you look at the skills manual for the teachers here, for the mentors here, debriefing is, just let me put it very simply, how do you feel? Let me put this to the audience. Well, let me have a different. I think, Gulsha, I'm putting this question out to you. How do you feel about this conference? Can somebody give the mic to Madam, please? How do you feel about this conference?
I think I'm very excited because it is taking into its purview all the people, all the stakeholders who are there to ensure that there's a safe environment for every patient that walks into a hospital. So it means to all people who are a part of it.
I think we should really have a loud round of applause from somebody with a management background telling us this is the spirit of healthcare professionals in Era University. Please a little louder, the tea is on the way. Okay, so ladies and gentlemen, debrief constitutes half, actually more than half, starting by the the exact guidelines. If you perform simulation teaching for 20 minutes, debriefing is 40 minutes. Debriefing is never in a way, it has to be with a round table, away from the site where you perform the simulation. You have to talk to them. Your reaction of what you felt, you have to analyze and you have to summarize. There are numerous methods of debrief, as Madam Sucheta said. We have a book, we've detailed out debriefing. But what stands out here is interprofessional debrief. That is, for example, if you do let's say an interprofessional scenario of trauma. Say, I am there, Dr. Priscilla, Dr. Rawat, Dr. Shalab, everybody is there. Always remember, interprofessional debrief has to be by a group of interprofessional facilitators. Only a nursing expert can feel what a nursing student is feeling. I cannot feel that, and what I call is feel equal to frame. I want all of you to develop frame of imparting patient safety curriculum using the fundamentals of interprofessional enhanced care with simulation-based education. The next slide, please. Well, the next slide, please. Well, I'm telling you a disclosure. I do not have any barriers, and that is because of course, as I say, Dr. Farzana Mehndi ma'am. I don't have any barriers. So when I go to her and I tell her, I have never seen a challenge in my life because of her. Anything, including COVID, by God's grace, and I keep my fingers totally crossed on that. But you do have challenges. Okay, now we are far from ideal. What is the first challenge? The time management. If I have to coordinate a teaching session with Priscilla Madam and Rawat Sahab, I have to keep in mind, number one, their learning objectives and their teaching schedule. Just because I want to plan an IP session, I don't decide it, or Madam doesn't decide it. So time management is very, very important. We have to keep that in mind. You have to align your learning objectives. There cannot be repetition of learning objectives. In an IP session, the learning objectives are also interprofessional that you have. Another point that you have faculty development, as Madam has already talked about, the community of practice, which we have already overcome. Financial barriers, yes, and our ma'am is an absolute champion of using low resources, and she says I can make a suture pad out of, she told me I needed a suture pad 12 years, 13 years back, and I told her, I said, ma'am, what am I supposed to do? I had a medicom next day. She said, to mochi ke paas jao. So I walked up to the mochi. And that's where I got my first suturing pad for my sim lab. And of course, the hidden curriculum, you have to see how your mentor learns to do what so you can improve upon it. The next slide, please. Okay, we've talked about this enough. The next slide, please. We would like to share with you a very brief video of our endeavors and our milestones that we have achieved in Era's University with patient safety, celebrating patient safety within the medical college, within the university, with the ethos of interprofessional education. Please play the video. slide. Thank you, ladies and gentlemen, and this is an ERA's presentation.
Thank you, Dr. Anuja. Thank you, Dr. Farzana, Dr. Sucheta, Dr. Anuja, for this really wonderful presentation. You know, it was truly educative. Madam laid the groundwork for what the session was about to be, and the dream of patient safety. Dr. Sucheta told us about how she would bring this patient safety from dream to reality through curricular involvement. And Dr. Anuja told us about how much of it is already real and all the things that you're already doing about educating students for patient safety. So a really truly great presentation. I take away a lot from it, and I hope the audience does too. Thank you. Thank you all. I think the students have to rush for class. They are busy now. Maybe they have a class.
Please settle down at the back. Please wait for a moment. Sit, please sit.
They're going for tea.
Now please go ahead, Shiraz.
I'm really thankful to ma'am for giving such an informative statement, and your early video was emphasizing in how to manage the golden hour. That was wonderful, the way you told everything. And regarding ma'am, interpersonal, like you said, that how the professionals should come together for patient safety, that has become a very crucial thing, and especially when I'm representing entire North and Northeast India in National Allied Healthcare Professional Council. I'm representing Nutritional Profession Council of India and member over there. Ma'am, this is one question which is coming out in front of NCHP also. And we are working that the interpersonal relationship and bringing physiotherapists, occupational therapists, emergency trauma specialists, speech therapists, dietitians, nutritionists, all together with clinician will definitely bring this patient safety goal attainable and achievable. So I'm really thankful at ERA you're practicing it and making it, we can doable kind of thing. So thank you so much.
Thank you, madam.
Thank you, everyone.
Shall we ask the audience if they have any questions?
Yeah, any queries from the audience?
Any queries from
the session is
younger
open for
audience?
questions.
From any queries from the younger
Anyone?
audience?
Okay. Thank you so much.
The presentation was great. Left people's questions. Thank you.
Okay, thank you all the three speakers for such an exceptional talk. With heartfelt gratitude, we now present mementos to our distinguished chairpersons and speakers as a token of love and appreciation for their meaningful contribution to this event. And for this, I request Professor Dr. Jamal Masood, sir, Principal and CMS Eraz Lucknow Medical College. Sir, please come on stage to present a memento to the chairpersons, Dr. Vimla Venkatesh, ma'am, and Dr. Uma Gupta, ma'am. Firstly, to Dr. Vimla Venkatesh.
I would like to say a few words. Am I permitted?
Yes, sir. Yes, sir.
I have worked with Vimla Venkatesh for a very long time in the HIV Sentinel Surveillance Program. She was a microbiologist of 𝐂𝐨𝐲 and I as a committee member. So we have a very, very long association.
मैम को दे जल्दी दे दी
Clinical and procedural skills that was there. We have all the clinical skills modules which have been, given under NMC for the skill training.
I will definitely go through that and also present it to the library.
Yeah. Okay.
Okay. Next, I request Professor Dr. Uma Gupta to please come and receive the memento. Thank you, sir. Thank you. Now I request both the chairpersons to please come on stage, Dr. Vimla Venkatesh and Dr. Uma Gupta ma'am, to honor all the three speakers. First of all, I request Professor Dr. Farzana Mehdi ma'am, Honorable Pro Vice Chancellor of Era University. Next, I request the organizing secretary of this conclave, Professor Dr. Sucheta Dandekar, ma'am. Now I request Head Department of ENT, Professor Dr. Anuja Bhargav, ma'am, to please receive the memento.
Only concise to just any device. It can be any tool or change in the system or the environment which can lead to the betterment. So the application of knowledge is technology, to be precise, and it is quite a big honor to introduce our next speaker, Dr. Pragnesh Vacharajani, and is the founder of the 𝐻𝐚𝐭𝐢𝐞, and affiliation is of IMA-FFPAI, and he holds a key position as an honorary secretary of FFPAI, and he has been in the past president of IMA Ahmedabad also. So I welcome Dr. Pragnesh for the next. Thank you.
Good morning all. So it is thanks to the organizing committee and especially Sucheta ma'am for having me here today to talk to about a topic on healthcare technology which is very close to my heart. And I'm fortunate that I'm speaking after a tea break. So I think all of you are energized and recharged to attend one more session. And as Madam has said rightly in the session before, I was overwhelmed by the amount of work that Era University is doing and about the big jargons in big words. A person like who has left an institute years back, maybe 3 decades back, and is back in an institute which is doing a wonderful work. I've seen your website and all. There are a lot of tech solutions that Era University and medical colleges are using. So I'm really happy to be here today. And I'm coming from Ahmedabad, so I will first ask the question, 𝐶𝐚𝐭𝐢𝐞𝐳? How are you doing? So this is a very important topic. Lekin I was just listening ki every time every speaker comes and was giving some advice to the interns. अरे बेचारा अभी 4.5 साल की पढ़ाई खत्म करके मुश्किल से बाहर निकला है, रिलैक्स हो रहा है, नीट पीजी सर पे बैठा है, कितना करेगा? बच्चे की जान लोगे क्या? थोड़ा टाइम दो बच्चे को रिलैक्स करने का. और अब मैडम ले आए करिकुलम पे रिवीजन करना है. ऑलरेडी जितना है उतना खत्म नहीं कर पा रहे हैं, बराबर, क्योंकि ये जो भी चीज सिखाएंगे वो नीट पीजी में पूछेंगे नहीं, तो पढ़ेंगे क्यों, राइट? सो देयर इज अ प्रैक्टिकली अ mismatch between what is exactly going on and what ideally should be going, but still it is a very right step that newer things are coming into the curriculum. हम curriculum revise करते जा रहे हैं. That is a very important step because we need to be proactive. और हम सब बात कर रहे हैं AI is a very essential tool. We talk about that in the next part of the talk. So I proudly call myself as a health tech catalyst. My job is to make healthcare professional use technology in day-to-day life and practice. अब लाइफ के बारे में तो I don't need to teach you all. मुझे पता है कि सुबह उठने के फौरन बाद और रात को सोने से 1 मिनट पहले हम क्या करते हैं? We check our mobiles. उसमें मैं भी आ गया. Don't worry, I am not an alien. I am also a human. So the first thing that we do, so personal और टेक्नोलॉजी इतना हावी हो गया है हम पे. अब लोग बोलते हैं ना कि इसका उपवास करो, ये करो. अब टेक्नोलॉजी का उपवास का भी अभी वो रील्स वगैरह बनने लगे हैं. तो things are changing, but technology is here to stay. It is for good for the end. Let me tell you, friends, the next decade, I do not see a big innovations happening in the field of healthcare. In anything or one thing that will change the way the treatment is being delivered to the patient is the advancement in the field of technology. That will change the way we doctor practice, and that will change the way society engages with the doctors. So everybody needs to learn it, and that's a part of everyone's life. So we are, since last 2 days, we are discussing about patient safety. I have seen the recap of yesterday's talk and a good elaborative talks today morning itself. Medical errors, as we all know, remains a major cause of preventable harm. मतलब उसको रोका जा सकता है अगर हमने ध्यान दिया तो. And with the, as I said, with the advancement of technology, day in, day out, everything is now getting digitized. It is required also. But it is now, so healthcare is now deeply dependent on the technology. And most of the professionals, in whichever capacity healthcare professional, whether you are a nurse or a ER registrar, doctor, academician, a teacher, or whomsoever you are, you all interact with technology directly or indirectly, whether you are a lab person, radiology person, whomsoever you are. आप नहीं यूज़ कर रहे हैं तो आपको कोई रिपोर्ट भेजेगा जो आपको टेक्नोलॉजी टूल का यूज़ करके देखना पड़ेगा. तो some way or the other, you are forced to use technology, in which is the need of the hour. So errors today, previously were individual generated. Now the system, the entire ecosystem of the health tech they generate a lot of errors in which we need to be careful about. Now how medical errors had evolved. Previously हम देखें पहले तो क्या था कि डॉक्टर को पता नहीं था गलती हो गई, पेन इन एब्डोमेन था, he couldn't identify that is appendicitis, or wrong diagnosis, wrong treatment, this and that. So there was knowledge gaps. I don't say वो अभी exist नहीं कर रहे हैं, शायद उसके बारे में हम बात नहीं करेंगे. फिर individual mistakes, it depends upon the interpersonal skill. कि आपके पास patient आता है तो what priority you will give it to the patient. क्या देखेंगे patient में first, that against depend, we were just discussing at the tea time, that depends upon your profile, clinical profile. आप intensive से तो आपको बड़ी बड़ी चीज़ें पिप्टास ही दिखेगा. आप मेरे जैसे फैमिली फिजिशियन हो तो आपको वायरल दिखेगा. Likewise, so different perspective has different things. But today, the interface, the health tech interface that we use, the workflows that we use, these failures becomes a source of medical errors today. Alert fatigue. आए दिन नोटिफिकेशंस आते हैं, पेशेंट्स ने ये रिपोर्ट. अब अगर आप कोई EHR सॉल्यूशन यूज़ कर रहे हैं तो द टेक कंपनी विल प्राउडली से यू विल गेट अलर्ट्स फॉर एवरीथिंग. पेशेंट ने BP मेजर किया, अपलोड किया, एक अलर्ट आ गया. पेशेंट ने कुछ घर पे कुछ रिपोर्ट करवाया, उसके दिमाग में आया कि आज फ्री कैंप चल रहा है, रिपोर्ट करवाया, उसका एक अपडेट आ गया. एंड एंटायर डे यू गेट बीप अलर्ट्स ऑन योर मोबाइल एंड ऑन योर डिवाइसेस. सो दैट इज अलर्ट फटिक. एंड सम ऑटोमेशन बायस. हम लोग काफ़ी मैनी थिंग्स आर टेकन फॉर ग्रांटेड कि ये टेक्नोलॉजी से हुआ, ये ऑटोमेटिकली ये तो ये अच्छा ही होगा. सो एरर्स हैव नॉट डिसअपियर्ड. द सोर्स ऑफ एरर्स इज चेंजिंग. Now, let's talk about EHRs, that is electronic health record. Now, this is, let me friends, having said everything, let's think of medical errors की बात करें, किसकी भी बात करें. This is the most essential part, and everybody needs to adapt the revolution that is coming up. Now, where EHRs are good at, it is good at continuity of care. With the advent of solutions like Ayushman Bharat Digital Mission, now all of your patients will be having an Aadhaar card. And that data will be interoperable only if you are using a software that is Aadhaar enabled. So unless you are using an EHR, how the patient data portability is possible? It is not possible. So using EHR is must, and Government of India is pushing like anything for the adaptation of this EHR and EMRs in practice. And for the first time, the doctors and the healthcare professionals are being incentivized to use ABHA-enabled software and write prescription, and because government wants the adaptation in the large scale. In any initiative, whenever it has been first been introduced, you can't introduce with a force. So government is playing smart. कभी कभी इंसेंटिव स्कीम चालू करती है, 3 महीना बंद कर देती है. नाउ दे हैव स्टार्टेड अगेन टिल द मंथ ऑफ मार्च कि जितने भी प्रिस्क्रिप्शंस or lab request or any interface request that a healthcare professional is generating, the healthcare professional or hospital and the EHR company who is providing that solution gets rewarded in form of token. But if you have a large pool of patient pool, that token is very big. So that is very important. Legitibility and access. The patients are mobile today. आज यहाँ है, कल वहाँ है. They are moving because of place of work is changing, place of education is changing. So data operability, अगर हम EHR use नहीं कर रहे हैं, that is impossible. So must be used. And availability of data. We need lot of data for research. Still, in lot of things we rely on lot of data from Western countries for disease prediction, this and that. We do not have our indigenous data. And as we talked about AI, LLM, this and that, all the models, all the good amount of data, India lacks a quality data as far as healthcare is concerned to have precise prediction and etc. by using AI. So that is very important that every healthcare professional must come to a single platform, and Ayushman Bharat Digital Mission is officially allowing the healthcare professional and the health tech companies to anonymously allow use of this data for the country's LLM purposes. That is officially being allowed. So if an healthcare professional is using any Ayushman Bharat digital enabled healthcare system, he or she can officially monetize his data with the government of India by providing it for research. So that is official. So that is these are the good part. But कहाँ गड़बड़ शुरू हो जाती है? वही सी नकल में अक्ल नहीं, copy and paste things. We used to make lot of templates. Left का right कर दिया, male का female कर दिया, operative notes की copy and paste हो जाती है क्योंकि लिखना भूल गए हैं. So whenever we generate any document, one has to read before sending it to anyone. Could it be patient? Could it be lab? Could be anything? Because there are lot of look alike, sound alike test as well as medication. और आज के ज़माने में तो क्या है? We talk about transcription. मतलब when we are with the patient, हम बोलते हैं the entire conversation get recorded and documented. तो एक patient से बात कर रहे हैं, छोटू चाय ले आना. किसी का phone आता है, the patient is having chest pain, we are talking to somebody on phone, क्या lose motion हुए हैं? Because ये तो voice to text है. Everything will be recorded and transferred to the system. So वो preview देते हैं, लेकिन करते कितने हैं? So that's why we need to always be careful when we use technology. Technology saves a lot of time. It improves your quality of practice, लेकिन it is very important. And one more important part, loss of clinical narrative. There are solutions available कि ER में patient आया, जैसे मैडम ने वीडियो दिखाया, उठा के लेके आए, तो the resident will quickly put in the details कि patient blah 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 यहाँ गिरा, ये लगा, head injury blah blah blah. AI will give a diagnosis, लगता है head injury है, CT scan करा दो, नीचे पाँव टूटा हुआ किसी ने नहीं देखा. So technology can support you. और मैं always बोलता हूँ कि कोई भी AI tool use करने के लिए PI is very important. PI means personal intelligence. Unless your PI is good, AI is a disaster for you. So everything needs to be used together to prevent errors. So then there are a lot of clinical decision support system. काफ़ी सारी चीज़ें आ गई है जो हमको support करती है. There are various courses, various things that are available जो एक clinician को assist करते हैं in taking right decisions. But क्या होता है? As I said, alert fatigue. ICU में नहीं होता. When we have attached a monitor to the patient, it keeps continuously beeping. The nurse will go and silent the alarm. बहुत आवाज़ करता है, काम ही नहीं करने देता. So at times we miss an important critical trigger error. So लोग थक जाते हैं. और पर्सनल मोबाइल में जो व्हाट्सएप और इंस्टाग्राम के नोटिफिकेशन बजते हैं वो तो अलग है. तो इंफॉर्मेशन ओवरलोड हो जाता है और कभी कभार गलतियाँ हम कर देते हैं. सो ये जो प्रॉम्प्ट्स वगैरह इसको इग्नोर करते हैं, दैट कैन लीड टू एरर्स. और जैसे मैंने बताया, जब सब नोटिफिकेशन देने लगे, कोई नोटिफिकेशन काम में नहीं लगता एंड वी मिस इंपॉर्टेंट पॉइंट्स एट टाइम. नाउ द AI, the buzzword going around everybody is saying कि AI ने healthcare में ये कर दिया. Yes, AI is definitely a boon if used rightly. But as I said earlier, you need to have a good PI to use AI. ये सारा prompt engineering है. आप garbage डालोगे garbage मिलेगा, अच्छा डालोगे अच्छा मिलेगा. So whenever you are asking anything to the AI, please be specific. You ask as per your personality and the things that you give your background. I am Dr. So and so. I am doing this and that. I want exact information on this related to my field, and that too from India or something else. And please ignore peer-reviewed studies. Only look for the original research articles. तो जितना अच्छा input दिया उतना अच्छा output आएगा. Otherwise it will be a waste of time. इतना लंबा document generate होगा, you will get exhausted. And I know the headache of teachers, because now all the theses and the papers are written by AI. तो अब ऐसे AI tool भी बनने लगे हैं कि you give command to the AI, make it look like that this is written by a human. तो वो पूरा AI transcript को ह्यूमन इंटरफेस में कन्वर्ट करेगा कि दूसरा सॉफ्टवेयर पकड़ नहीं पाए कि AI से लिखा है. लेकिन ऐसा नहीं है, वो पकड़ ही जाता है. तो आई एम सीइंग इन लॉट ऑफ जर्नल्स व्हाट दे आर राइटिंग, अप टू 80% कंटेंट हैज टू बी ओरिजिनल, 20% AI से कॉपी किया हो तो चलेगा. अब ऐसा ऑफिशियल गाइडलाइन आने शुरू हो गए. सो वी नीड टू बी केयरफुल. सो AI इज वेरी इंपॉर्टेंट फॉर रिपीटेटिव टास्क. हम जो रोज करते हैं, लॉट ऑफ एडमिनिस्ट्रेटिव टास्क, pattern recognition like reporting of X-rays, CT scans and MRI. You are doing hundreds of X-ray. You have got large database, and precisely it is being very good used in radiology now. So pattern recognition बहुत easy है कि ये tuberculosis एक बार सिखा दिया तो वो tuberculosis कभी miss नहीं करेगा. Likewise, AI can help in risk prediction. There are risk prediction scores now available as soon as the patient reaches you. You input some critical data of the patient along with the family history and everything. So when you get a patient of chest pain, maybe in a periphery, जहाँ tertiary care नहीं है, वहाँ cath labs नहीं है, so depending upon the risk score, AI will predict that there are chances of heart attack in this patient is this much. Kindly refer this patient urgently to the nearby center. So जहाँ facilities कम है, जहाँ infrastructural issues है, वहाँ AI boon है. At the same time, इंस्टीट्यूट जैसे आपके बड़े इंस्टीट्यूट में भी यूज़ कर सकते हो, लेकिन विद अ वर्ड ऑफ कॉशन. एंड इट कैन बी ऑलवेज ए सपोर्ट सिस्टम, बट इट कैन नॉट रिप्लेस द ह्यूमन रिस्पॉन्सिबिलिटी. सो इफ़ यू वांट टू प्रिवेंट एरर्स, दिमाग जहाँ है वहाँ रखना ज़रूरी है. स्क्रीन फटिक नहीं ज़रूरी है. और कहाँ गड़बड़ हो जाती है, जैसे मैंने बताया, ब्लैक बॉक्स डिसीजन. AI ने बोल दिया कि इट लुक्स लाइक एंट्रिक, वी हैव स्टार्टेड दिस थिंग, वी डोंट थिंक अबाउट कि देयर इज एन एपिडेमिक ऑफ मलेरिया गोइंग इन द कम्युनिटी, जो AI को नहीं पता है. राइट? So data bias, as I said, data biases are very common with AI. There could be manipulative biases in future. That there's certain amount of data may be introduced in one way or the other, which makes clinician to do. This could be a new warfare weapon. That it makes clinician to take wrong decisions, make wrong policies, and misguide the entire system. So that is also possible. So we need to be careful about that to prevent this over-reliance and prevent medical errors. Lot of medication dispensing technologies are there, and now government is wanting everyone to write an e-prescription, right? Still, in e-prescription also, obviously the copy-paste error comes, right? So there are lot of multiple drugs in India. You can, आप जो नाम चाहो ड्रग का रख सकते हो. There is no reason. आपको जो मज़ा आया आपको उसने नाम रख दिया. So everybody likes to have some their favorite prefixes जो ऑलरेडी मार्केट में एग्जिस्टेंट है, वो नाम भी आप चाहो तो कोई भी छोटा प्रोडक्ट का रख सकते हो. तो योर पिप्टास कुड बी एंटीबायोटिक, योर पिप्टास कुड बी पैरासिटामोल. सो इट कुड बी एज सिंपल एज दैट. सो नीड टू बी वेरी केयरफुल. एंड नाउअडेज दीज ऑनलाइन फार्मेसीज, दे आर हायरिंग सो कॉल्ड डॉक्टर्स. जो पेशेंट फ़ोन पे नाम लेता है उसका प्रिस्क्रिप्शन लिख के मेडिकेशन सप्लाई कर देते हैं विदाउट वेरीफाइंग द एक्चुअल प्रिस्क्रिप्शन. सो ये नया थ्रेट of medical, this medication error has started coming. So that leads to lot of issues, and lot of patients are suffering because of the look-alike and feel like medication is coming. So wrong drug selection. और आप EHR में काम कर रहे हैं तो when you search for something, a drop list will open. So गलती से if you have made a wrong click, and while submitting you do not review the prescription, entirely a different drug could be prescribed to your patient. So patient को anti-anxiety की जगह anti-hypertensive भी मिल सकता है, and which can lead to lot of problems. So automation is good, लेकिन दिमाग उधर लगाना बहुत ज़रूरी है. So as rightly said, automation reduces some error, but it amplifies the other. So need to be very careful on that part. So my friends, the core problem is not the technology. As I said, technology is very important. Technology implementation is need of the hour. But as Madam has revised curriculum, I say I couldn't find the word technology teaching in the new curriculum also. I don't know whether it will come or not, but the new suggestion also doesn't have any classes on technology. So when we visit medical colleges, when we talk to the doctors, उनको लगता है हम alien है, ये क्या बात कर रहा है भाई? ऐसा थोड़ी होता है. Why doctors need to learn technology? लेकिन it is as important as learning medical science because it is everything is connected now. So inadequate clinician training at any stage of your study, late exposure in medical education. जब internship में आते हैं या बाहर जाते हैं तब कहीं ऑब्जर्वरशिप करने जाते हैं तब पता चलता है कि इस इंस्टीट्यूट इज एक्सटेंसिवली यूजिंग टेक्निकल थिंग्स विच वी आर नेवर रेड ऑफ. और ये टेक कंपनी सारी फैंसी चीज़ें बना देती है लेकिन क्लिनिशियंस आर नेवर इन्वॉल्व इन द इनिशियल स्टेजेस. सो there is a poor alignment with the real world clinical workflows. We have got lot, so we are mentoring lot of startups. So when they make a solution, they are not aware about the real world scenarios or real world challenges that is happening around. तो वो कुछ ऐसा सॉल्यूशन बनाएंगे जो प्रैक्टिकल नहीं है. वो बोले इमरजेंसी में पेशेंट आए, इसको ये पहना दो. कौन पहनाएगा, कैसे पहनाएगा, हाथ पे लगाए तो क्या करेंगे? सो प्रैक्टिकल सॉल्यूशंस आर नॉट थॉट ऑफ. से पेशेंट को ट्रांसफर करने का स्ट्रेचर डिजाइन कर रहे हैं लेकिन उन्होंने 10 दिन उनको ER में बैठना पड़े. फर्स्ट टू सी हाउ द पेशेंट इज बीइंग हैंडल्ड इन ER, कैसे पेशेंट को शिफ्ट करते हैं, कैसे पेशेंट को एम्बुलेंस से नीचे उतारते हैं. देन you can say something about changing. You see reels on Instagram, my relatives suffered from this, so I thought of this innovation. एक एग्जाम्पल से कभी इनोवेशन नहीं होता. इनोवेशन इज अ जर्नी. You need to work through the entire problem first and then you can make some solutions. Then what should be done? My request to the madam, start early in the time of medical education. So as you are teaching patient safety in the UG curriculum and everything, so introduce everything like electronic health records, the lot of devices are available, lot of technologies, lot of variables the patient is coming with. See, because previously clinicians, see for example, if I give an example of diabetes, patient previously were coming with the only report of fasting and PPBS. 2 रिपोर्ट देखा, दवाई लेकी बात खत्म. अब पेशेंट 15 दिन का CGM का रीडिंग लेके आ रहा है. Nobody has taught me to interpret that reading. मुझे उसको AI को देना पड़ता है या लास्ट में मुझे देखना पड़ता है कि एवरेज क्या है, अकॉर्डिंगली आई प्रिस्क्राइब समथिंग. सो आई डू नॉट अंडरस्टैंड द थिंग्स विच आर बीइंग प्रेजेंटेड टू मी. मैं AI यूज नहीं करा लेकिन पेशेंट AI से क्वेरी लेके आ रहा है. सो दिस ऑल थिंग्स नीड टू बी टॉट टू द स्टूडेंट्स कि देखो भाई, दिस आर द थिंग्स एंड दिस इज नॉट द फ्यूचर. This is already here. I am not talking about anything which is not prevalent in India. Everything is here right now. So UG में सिखाओ, reinforce them in internship. सोरे बच्चे माफ करना, मुझे और कुछ internship में सीखना पड़ेगा. And post graduate training में you need to reaffirm the entire thing कि भाई ये करना ज़रूरी है. So that's where the entire cycle completes. So when comes out in the practice, he or she will be prepared कि मुझे EHR तो यूज़ करना है. मेरा पेशेंट आएगा, वो गूगल फीट से ये डेटा लेके आएगा, मोबाइल का ECG लेके आएगा, जो आई एम सपोज टू लर्न टू इंटरप्रिट इफ इट इज़ इम्पॉर्टेंट. वरना वो लोग घड़ी से ब्लड प्रेशर नापेंगे और ब्लड प्रेशर बढ़ेगा तो रात को 12 बजे आपको मैसेज करेंगे. तो वो भी उसको समझाना ज़रूरी है कि ऐसा नहीं कर सकते. सो पेशेंट सेफ्टी इज़ अ लर्न स्किल. सो द एजुकेशन फॉर टेक्नोलॉजी शुड स्टार्ट फ्रॉम द UG itself. एंड इट इज़ नॉट ओनली लिमिटेड टू UG. दी एक्सपीरियंस प्रोफेशनल से हमको सब पता है. गुजराती में बोलते हैं MBA, मने बधु आवड़े. बिकॉज वी आर practicing last 25 years. Who are you going to teach me about use of technology? It's not that. As I always said, we doctors and all the healthcare professionals, including teachers and practicing, we are always a student. We always be ready to learn something new every time. So every practicing clinician must learn how to use technology because technology evolves faster than training. You learned the fundamentals of medicine way back. For example, for a people like me, I graduated 30 years before, right? Absolutely, technology was nowhere in the picture at that point of time when I graduated. Now, Everything depends on that. Every other day, patient comes to with a similar problem. So, senior healthcare professional also need structural upskilling. Learning must not be punitive, it must be respectful. And I done a bit of branding here myself, 𝐏𝐚𝐭𝐢𝐞. So, we organize events which teaches and which promotes its use of technology among doctors. So, we urge people to, why don't you come and learn? Because for a healthcare professional, as madam, we were just discussing in previous lecture, to learn, unlearn and relearn. It is a continuous process for any healthcare professional. Possible hai कि whatever you might have learned 10 years before may not hold true today, and what we are learning today may not be true after 10 years. So it's a continuous learning, unlearning and relearning process. So technology obviously it's the same thing. So it is about adaptation, it is about not competence. It is required. But in private practice, it is seen that if you are a busy practitioner, nobody bothers about anything. Lekin as soon as your OPD start drying up, you start looking for क्या गड़बड़ हो रही है भाई. ये जो मैंने बताया ना कि जब चिड़िया चुग गई खेत, हम फिर देखना चालू करते हैं कि भाई क्या, what mistake we have done in our practice, we have not updated yourself. That's where the problem starts. So an important point, not for this forum, but the techies who make the solution, I tell them from very beginning, if you are making anything for healthcare, a clinician who is practicing must be there in your team. Because kuch bhi hai, as I said, anything that you make with a plethora of facilities available, but it is not user friendly. It is not giving me time to talk to my patient rather than forcing me to see at the screen is not gonna work. So I need a technology which keeps connect with me more with my patient. I do not want anything which detaches me with my patient. That is the first part. I do not want to be a typist. I do not want to keep typing every time rather than, and you must have heard about the plight of doctors in the Western countries. They do 2 to 3 hours documentation after the clinical practices get over. इतना भी नहीं चाहिए भाई, थोड़ा कम दो तो चलेगा. So when clinicians enters late in any technology design, errors are already built in. Already उसमें flaws है जो नहीं चलने वाला, time consuming है, नहीं चलने वाला. जब हमने first time, maybe before 15 years or something, हमने एक family physician association ने हमारे लिए software बनाया. I asked that person to sit with me in front for 8 days. मैंने कहा मैं कितना पूछ रहा हूँ देखो, क्या कर रहा हूँ देखो, उतना ही मुझे चाहिए. I don't want your wisdom. I want this to be practical enough to more informed family physician can adopt this solution. So this is very important. So human brain should be kept in loop. Technology should reduce cognitive load, support clinical judgment, but it should not replace reasoning. दिमाग बंद नहीं हो जाना चाहिए. Encourage blind trust, and human judgment always remains central to the patient safety. Whatever it is, if you are a clinician, if you are a nurse, if you are an administrator, anything, human judgment always remains central, and it has to be. Otherwise, because as I said, कितना भी AI, कितना भी ChatGPT आ जाए, human brain will always remain supreme if we take care of it. If we surrender to the technology and not use it properly, we will become slave. But if you want to be supreme, if you want to be at the top of governing the technology, it is your brain which should be awake and should be doing it. So from adaptation to safe use, training, continuous monitoring and governance is required. And buying technology is very easy. I have seen hospitals buying fancy EMR worth lakhs and crores of rupees, but only used in billing and discharge summary. No clinician at no places this EMR EHRs are used. Q, because there is no training, there is no motivation, there is no aim. Only thing, बिल में गलती नहीं होनी चाहिए वरना लॉस होगा. और बिल में गलती भी हुई, डेटा भी हैक हो गया, 3-4 महीने का बिलिंग भी गया. So that is also happening. So need to be careful and need to look for everything. So whenever you are using technology, the end user has to be kept in mind when you design anything, when you implement anything, and for that, starting from ground zero, training, sensitization, and program like this plays a very, very important role. So take home message, technology alone cannot prevent medical errors. Clinician training, as I said, must start early and it's a lifelong feature. आज चैट जीपीटी है, 4 आ गया, 5 आ गया, कल कुछ और आएगा, राइट? आज ये एप्पल फ्री दे रहा है, कल जियो ने फ्री दिया, फिर सब पैसा लेना चालू करेंगे. If you are over reliant on that, क्या करेंगे? Are we ready to pay? And clinician must be involved in taking technology decision, and patient safety always depends upon people, not just the system. Thank you very much.
Thank you, Dr. Pragnesh, for such insightful lecture. And as you told that for the technology, there should be always a man behind the technology for the governance and the monitoring of the product. Now, in this segment, I would like to add upon like few of the aspects like at our institute. We had this insight and we started this technology-related work, especially with the AI and the EHR, EMR, and hospital information system.
Yeah, I heard the sir talking about the prevention of bed sore and all. I heard the
in that one, for curtailing down the errors, we also took a lot of consumer insights. We made a team of the doctors. Then we included them in day-to-day practice, and we gave them the demo. Like we also did the alpha and beta trials of the softwares which we made for the normal hospital information system and the EMR. Now in this one, as you told about the clerical errors, copy and paste errors, and the template errors, what we did, we disabled it. We didn't give them the option of doing all those things. And secondarily, we also pioneered in implementing it at our OPD basis. In our OPD also, the registration starts, and from there only we start our electronic medical record. And in that one, in that segment, as you told, for the clinical decision making and overruling should be there. So we have given that option that directly you cannot take that judgment. You can overrule that also. So this is how we have implemented here, and it is all because of all the efforts of our esteemed management and administration. And thank you for all that.
And that is something unusual I am hearing about, because this is not a routine practice. So I must congratulate the Era University for doing this, because this is not the routine, because I keep visiting places, I have never seen that.
Thank you, Dr. Pragnesh. You have explained the technology and medical errors so simply. And you have very beautifully explained about the knowledge of technology is very important.
Yeah.
Where wisely you have to use the technology, the places where to use, places where not to use the technology, the integration of technology, AI to be used with great caution, especially with using your PI. And over-trusting is always disastrous. And adequate training and knowledge upgradation on day-to-day basis are the key to success.
Yes.
So these are the take-home points. So now the session is open for any specific questions. One or two.
Give me some time so I can ask ChatGPT to answer your questions. Yes, ma'am.
Don't you think that since we are having so much of software and AI coming into role, the uniformity across the country for a software is essential?
See, ma'am, that's where the Ayushman Bharat certification comes into picture. The government has laid down certain standards for all the EHRs and EMRs, and there is a certification level called M1, M2, M3, and these are interoperability rules, and there is an environment that government has defined. So once your EMR or EHR is certified with Ayushman Bharat, the parity automatically comes. Other than that, also for this EMR and EHR, there is an NABH accreditation also for this thing. And now hospitals are opting for digital NABH also, which takes care of these virus, antivirus attacks, and all the system flaws and everything. So that is already there.
Because
yes, that's a good point you have raised.
Is,
yes, ma'am. Yes,
right
ma'am.
now.
Yeah, that's a good point raised, ma'am.
Thank you very much. Thank you, Dr.
Thank
Pragnesh.
Yes, ma'am.
As far as the training for these technical use of technology,
We are trying to, in the this orientation program for our interns, we are having a session on how to use the hospital information system and technology. And for the postgraduates, when they are entering, we have a similar kind of a session which is documentation, case sheet, prescription writing, and OPD software.
Great.
So that is being done at a very grassroots level, but
still it's good that it is started.
So now what we are planning, that it should be a full-fledged session, maybe a half a day or so, because it is so important.
It should be done on a regular basis, full day, once a year.
So
just
now
like patient
after
safety, you
this-
can have a digital safety or digital literacy, whatever
sir.
name you can give.
So this is my take from this conference.
Thank you.
Thank you, sir, for enlightening all of us.
Thank you very much.
Thank you, sir. I would now like to invite Honorable Vice Chancellor, sir, to kindly felicitate our chairpersons. I request Dr. Avinash Agarwal to receive the memento. Next, I request Dr. Sharik to receive the memento. Thank you, sir. Now I request our chairpersons to felicitate our esteemed speaker, Dr. Pregnesh. Thank you, sir. Thank you, ma'am. Now I invite Dr. Saleha Rizvi to kindly take charge and begin the next session. Thank you all.
So good afternoon to all the respected dignitaries, esteemed faculty members, and dear delegates and participants. Now we proceed to the final segment of this conclave, the panel discussion on the theme Preventive Strategies Across the Care Continuum. To smoothly conduct the session, I may now invite our respected chairpersons on the dais. It's my great privilege to invite our first chairperson, Dr. M.M. Khan, sir, to the dais. Please welcome, sir, with a huge round of applause. Dr. Khan is Professor and Head, Department of Physiology at Career Institute of Medical Sciences and Hospital, Lucknow. Over the course of his career, he has served in several key leadership roles, including former principal and dean at CIMS, director, faculty academic programs, coordinator, medical education unit, just to name a few. His research interest focuses on cardiovascular and neurophysiology and has contributed significantly to academic scholarship with multiple publications to his credit. He is also a fellow of the International Council of Sciences, reflecting his commitment to excellence in the field of medical sciences. We welcome you, sir. Sharing the chair with him is Dr. Professor Tariq Masood, sir, Head Department of Biochemistry. May I request, sir, to kindly grace the dais with his presence? Dr. Masood is a distinguished biochemist and academic leader with over 13 years of teaching and research experience. His experience bridges foundational biochemistry with applied clinical practice, healthcare, and research. He holds numerous prestigious awards and publications to his repute. Please welcome both the chairpersons with a huge round of applause. May I now request esteemed chairpersons to kindly introduce and invite the moderator of this session.
First of all, I pay my regards and thanks to
Vice Chancellor and Pro-Vice Chancellor, and also Dr. 𝐂𝐨𝐧𝐜 to invite us to chair this panel discussion session. It's extremely beneficial. This conference is very nice. And today's conference, it gives a lot of information, a lot of knowledge to us. So I'm going to introduce Professor Dr. 𝐂𝐚𝐭𝐢𝐞𝐧𝐭. He is the Dean Students Welfare, Head of the Department, Dentistry, 𝐒𝐴RA's Lucknow Medical College and Hospital, Lucknow. Regarding the achievements, he is the holder of 7 patents, reflecting his sustained contribution to innovation in the field of dentistry. He is fellow of the Association of Trauma and Maxillofacial Surgeons, key patient head medical superintendent, 𝐒𝐴RA Lucknow Medical College and Hospital, assistant dean, 𝐒𝐴RA Lucknow Medical College and Hospital. Regarding notable awards and fellowship, number of papers are published more than 25 research papers in reputed national and international journals, and oral pre-management leads the area of research interest. So, thank you very much, sir.
So now I would like to invite all the panelists on the panel. The topic of the discussion today is prevention strategies across the care continuum, a dialogue. So the first people, the chair of the panel would be Dr. 𝐒𝐚𝐿 sorry, he's not here. So I would like to invite Dr. Priscilla Sampson. She is Principal Nursing College, 𝐸RA University. Dr. Zia Abbas from the Department of Physiotherapy, 𝐸RA University. Dr. Amrita Rao, she's from Community Medicine, ICMR, NITVAR. Dr. Ridham Banks from 𝐂𝐨𝐬 Department of Dentistry, Dentistry College. And Dr. Poonam Tiwari, she's from the Food and Nutrition Department of Paramedical University. Thank you very much. So, with the permission, I would like to ask them to start the discussion on the questions of prevention strategies across care continuum, a continued dialogue.
Thank you, Dr. Tariq. First of all, I extend a very warm welcome to all the dignitaries from 𝐸RA family. So welcome you, ma'am and sir. Before we start the session, I will just share a story. 10 years back, I was sitting in my dental OPD and our new software was developed. So discharge summary was given computerized. So a patient came to me and he had a printed discharge summary. So I have a habit that I inquire what all drugs they are taking. So usually we cater to a very poor social group which comes to us. So I was inquiring of the drugs. So he was taking metformin and metrogyl together for 20 days. Actually, he was prescribed metformin for 7 days, but the pharmacy person has administered both the drugs and he was taking both the drugs simultaneously. So this is a very frequent thing which happens in our OPD. We come across these things on daily basis and we try to correct it. So a feedback was given to the software team. So now what they have done is, you will receive a prescription which has written in Hindi, सुबह नाश्ते के साथ, दोपहर के खाने के साथ, खाने के बाद, खाने से पहले. So it makes, when we are making policy, we are discussing jargon of terms, artificial intelligence, robotics, but what we need to understand is that we have to cater a very basic framework of social thing. So we have to keep that thing in our mind. So today's discussion will start with this thing only. Every potent risk is a prevention opportunity. So I will start today's discussion with Priscilla ma'am. Ma'am, how do you think nurses will operationalize prevention across the care continuum in the day-to-day nursing practice, and how it will make a difference in the coming days?
Thank you, Dr. Siddharth, for the question. And to start, to give the answer to these questions, I would just like to take you, because not everybody is a nurse in this room, so I would like to take you to the journey a day of a clinical nurse, how it starts. So she comes to the ward, Probably she is having a biometric. Now we have biometric attendance, so she is punching in there. She's coming to the ward. And she's coming to the ward, so the first thing that she must do is to wash hands. Because she has touched the biometric machine, which probably so many people before her done. Maybe some had flu, some had some other condition. But she walks in a hurry because probably she is late to the ward. And she just comes and starts doing her. So there it starts the time that a nurse enters the ward. And then comes the major thing, which is taking over, handing over procedure with what nurses do. So the night shift duty nurses will hand over to the day duty shifts. And that is, I think, is a very important part of a nursing care, because there is the time when many things can be missed out. So when we are having bedside report, and we are taking the nurses, day duty nurses, patient to patient, are we giving the key things or just the routine thing? Okay, iska ye ho gaya, iska vital signs check ho gaya, check to ho gaya. But am I telling if there is anything abnormal that I have noticed? So that is what, giving the report. And not only that, not only just kya hua hai, but nurses need to see what is environment. Patient's IV is hanging, the bottle is hanging there. Whether the fluid is there, it is still on. Whether the IV, the cannula which is there, whether blood is there. So you see that every detail, it's not only, so the eyes are observing, so observation comes there. The reporting, the verbal communication is there. So that's how the nurse is, and okay, once all that is finished, and every aspect you can see that lies the patient's safety. Any point is missed out there can cause harm to a patient. Then start the routine. Nursing in foundation of nursing in very first semester of a nursing student, we teach them what is the basic care for the patient. So starting, with the hygienic, care. We tell them what is their nutritional care, what are their comfort care. I just want to give you one example. I was just going one day for rounds to a ward, and that was a surgical ward, and I was going and asking the students what they're doing in the ward. And there were PG students, there were BSc students, and there were surgery patients who were lying on the bed, all covered up. It was like 10:30 in the morning. So I asked the students, did you ambulate your patient? We are talking about DVT and prevention of that. That is also a risk to the patient. And they said, nahi ma'am, patient ki surgery hui hai to patient so raha hai. So you see, even the staff nurses missed out. They also did not say that patient needs to, unless there is a contraindication which is written in the charts. Are we doing that? So there also the nurse's role comes, And also there is a medication. We talk a lot about medication error. We had yesterday also, today also, medication is the responsibility of the nurse. Giving injection, oral medication. Oftentimes we see that nurses are so busy, so they come and give medication, the tablets in the hand of the relative or the family members. They say, "Aap apne mareez ko khila lijiyega." We don't know whether they have already, swallowed that or they forgot. So we are not even checking that they have taken their daily dose. Then comes the injection part. We all know what procedures, what IV they have to give, IM we have to give, where we have to give, what are the site. So any mistake is done there that also, put the patient in harm. So all these things are there, and then comes the transferring of the patient. Sometimes we take it very, casual. Patient has to go to extra department, patient has to go to OPD for checkup, patient has to go to OT. We say, acha, mareez ke relatives kam kehte hain, aap le jaiye. We don't see whether wheelchair is working, because patient can have fall injury. We don't see whether the patient is covered when we are taking in stretcher. There's no privacy to the patient. That is also psychologically we are kind of, harming the patient. Patient is just going exposed, whether they have, worn what they're supposed to be wearing. So these are the things we don't take. Patient is sick. Are there side rails? And comes the feeding part then. NG tube feeding. So that's another example. NG tube feeding. How many of us really check? Nurse's duty is to check whether the NG tube is at the right place or not. And we are taught, and we teach our students, there are various ways to check. So are we checking or we are taking granted? There again patient safety lies. So every aspect. Other thing is patients elimination of leave. There are patients who are in the ward on urinary catheter, Foley's catheter. Now, where I was a student in CMC, it was not the job of the relative or a fourth class worker to empty the, the bag. It was the duty of the nurse, because we were taught how to open, how to close, it should not be touched, see the urine color, all those things are again talking about patient safety. And they tell us, our sister, itta doso hai. Pata nahi, they saw that doso is there or not. We don't know. Intake output is again not maintained well, especially for patients who really need, a strict intake output chart. The other day, again, I went to the ward and I saw a patient on urinary catheter. The tube was kinked. So that means there was no flow of urine which was coming in the bag. So these are the things that nurses do in everyday's, life, and so many other things, reporting and documentation. I will, finish with that. Reporting and documentation is very much lacking. Again, another example, 2 weeks ago I was in the ward. I'm just giving these examples because I'm seeing this example, and I'm sure that many of you have also seen. So I went there and patient, they had checked BP of the blood pressure of the patient, and I asked the student, I said, how much is the BP? She said 90/60. So I said, did you see the previous reading? Whether it has deteriorated from the previous one, or patient is having low. Then she saw that there was a documentation, but she did not report it. So I said, did you report to the staff who is on duty? Because she should know, and then it should be reported to the doctor who is on duty. So there you see, she just checked. Her duty is to check and record. And then what is happening? So these are the things that we put our patient at risk. These are very small things, but actually not small things, because they can risk the life of the patient. So that's how our nurses, day to day, it is taught to them, and it is our duty to do these things, to take part, a huge responsibilities of nurses to prevent patient harm.
Just now we were having a discussion with Dr. Vasunkar sir while I was having tea. So he told that nurses have to be empowered, because in India there is a communication gap between the doctors and the nurses. Egos play. So you cannot help that in our scenario, and we face that on daily basis. So he was telling that until unless we empower our nursing staff, the things are not going to improve, and that is very true. So next, since it is an interdisciplinary discussion, I think physiotherapy is the next thing which comes to our mind. So I will have your take, sir, Dr. Zia, sir, on the prevention strategies what physiotherapists can offer to our healthcare system, in our healthcare system.
Okay. Good afternoon, everyone. From a physiotherapist perspective, patient safety is also has a very important role to play. Basic, हम लोग कुछ basic points पे focus करके हम rule out कर सकते हैं. जैसे if somebody is having at their own age अगर कुछ balance issues होता है, he or she may have some difficulty in walking, gait patterns में changes आते हैं, तो उसके द्वारा हम लोग mood changes हो रहा है, behavior changes हो रहा है, इन सब चीज़ों को ध्यान में रख के throughout the day if anybody is having a lethargy, attitude, weakness लगी रहती है, उसके अलावा in my concern कि अगर patient को there is a loss of inappropriate pain during any activity या किसी position में there is numbness, tingling for a prolonged period rather than usual, so these things should be taken care in consideration to prevent for the patient safety.
Especially in geriatric patients, we have seen that falls are a very frequent thing. So yes, can we do something to prevent that? Or
so in geriatric patients, we have to consider the issues, what sort of condition usko pehle se hai, what sort of disease he is having, is there a blood pressure issue, hypertension, या other neurological disorder, and while performing physiotherapy, we have to take a note of that condition too. कि उसकी muscle power कितनी है, mobility status क्या है, whether he is independent partially assisted condition है या support की ज़रूरत है, तो these all things contribute to the patient safety.
Thank you, Dr. Sia. So, moving on, I will request Dr. Rhythm to kindly elaborate how can preventive oral health care be better integrated into the mainstream to improve health-related services.
Thank you, Dr. Siddharth, and a very good afternoon to all. And a very important aspect of any type of medical care, be it of any speciality. And first of all, we'll all have to accept and understand the fact that it is only and only possible if we all accept it as a professional responsibility and not as an additional burden. Sometimes many efforts are there, guidelines are there, wherein we are told to make checklists or to ensure more safety measures. As we are already burdened with so many patients and teaching, undergraduate teaching, postgraduate teaching, somewhere down in our mind we start feeling this as an extra burden and an extra measure adding to our daily work. But it is very important that these points of safety, these are taken care of. Like ma'am was also saying, that safety is just not limited to the treatment part. When the patient is leaving the hospital on a wheelchair or on a stretcher, that particular wheelchair or stretcher is also working properly. It is also a part of that safety measure. Now, talking about the oral health care sector, we must understand, and in today's scenario, we cannot afford to keep oral cavity as an isolated organ which is not a part of the body. Sometimes this happens. And somewhere, as doctors, we only are responsible for it. We can't blame the patient for it. When the patient comes to us in our OPD, he hides the medical history. And maybe not intentionally, but because he is not aware that the medical aspect, the systemic history is also important, and it is a bi-directional thing. Like if we talk about diabetes, India is becoming the diabetes capital of the world today. If we are talking about diabetes, we have to understand that guidelines and studies, they have declared periodontitis, which is a chronic infection of the gums and the bones surrounding the teeth. It is now recognized as the 6th complication of diabetes mellitus. And it is a bi-directional thing. It is a two-way street. Not only is the diabetes mellitus affecting our gums and teeth, it causes the inflammation the diabetes is causing in the body. It hampers the gingival and the bone health of our oral cavity, and bone loss is seen. Not only that, but if a patient is a severe periodontitis patient, we have seen that it leads to a poor glycemic control in that patient. So it is a two-way street. Many things, as dentists, we are sometimes the first one who is coming in touch with a asymptomatic adult patient. Patient might be thinking that I do not have any disease, but the dentist has a good chance to take some history, to take the blood pressure readings, or to give some blood test before some procedure. By that only the patient is coming to know that I am having some type of pre-diabetic stage or a pre-clinical symptom which I am not aware of. Secondly, when we talk about the ICU settings and the critical care unit settings in hospitals, there also the oral health is definitely, because the patient is intubated, he is mechanically intubated, so sometimes, every time in fact, the oral health is compromised, and it is very difficult to maintain oral health in that condition. And it is seen that the bacterial colonization in the oropharynx, especially the Treponema species, streptococcal species, E. faecalis, they all are colonized, and sometimes they are aspirated into the lungs, leading to the ventilator-associated pneumonia. Studies have shown that if some preemptive measures are taken before intubation or during that period, if a dental healthcare provider or a dental hygienist is empaneled in that unit, or if the nursing staff can be trained on taking good care of the oral health part also, which sometimes takes a backseat or it is neglected, then the incidences of ventilator-associated pneumonia, they are decreased. There are many more examples, like we always take medical history of the patient when we are working on the patient for any procedure, but the medical physicians, they do not take oral history or any oral screening before they are giving their medications or doing their procedures. So it is important that oral health screening is included in the medical health records also. So what we need is shared electronic health record systems, or systems where there can be a dialogue between the physician and the dentist, and a collective and a collaborative decision can be taken when we are working on the patients. Thank you.
Thank you, ma'am. I think half of the things can be managed if we pick the phone and just give a call to the consultant. Most of the times we hesitate in doing that. We are simply following the records, and it results in, so many times it results in catastrophe. We have got psychiatric patients who are scheduled for ECT. So we have to check for loose teeth. And so we just call, Dr. Kushag is the in charge. So we'll call him and we'll tell him that there are certain tooth which needs to be removed before you take the patient for ECT. So he will say, please do the needful, sir. But if I follow the entire channel, somewhere the things misses. So my take is that all healthcare professionals, at least just pick your phone, give it a call. It matters only for 30 seconds. If you can talk with each other, things will improve. So if we have to improve our services, I think community, it has to start at community level. We have to take care in the hospital, and we have to follow the patient back home. So with that, I think there is no other better person than Dr. Amrita. Can you please give your take on?
Yes, a very good morning to all of you, and thank you to the organizers for inviting me. I basically deal with our institute and our mandate. We've been dealing with a lot with the HIV and the sexually transmitted infections. So when it comes to the community and comes to the disease, there is a lot of stigma and discrimination around the disease, and even among the doctors. I think now, though there has been a change, but we always see that before any surgery, randomly there is a list of blood tests that we all do, and one of them is HIV. And unfortunately, the patient is not even counseled and informed that we are doing this entire band of laboratory tests that we are undergoing. Sometimes, luck by chance, he just turns out to be HIV positive or hepatitis B positive, and he is just told that you go to this particular center and this particular ART center, not even aware of what the situation is. So somewhere from the patient perspective that I would take into consideration, it is important that as a physician, as a doctor, whenever you are doing a blood test, communication is something which plays a very, very important role, and also linking of the patient to the correct health services. We know that the ART center gives you free medications, or even the STI centers do give you free medication. It is important to connect them to the correct health facility so that the treatment and the medications remain and they adhere to it, so that we automatically have a better footfall for a lot of things. Thank you.
Thank you, ma'am. Can you just comment on how to prevent any mishap with community perspective?
In terms of community perspective, it is important to have whenever we are giving any particular newer interventions or newer drugs, for those kind of perspectives, we need to have, it is important to engage the community leaders, and the community perspective is very important. A socio-culturally appropriate intervention needs to be brought about. You cannot bring in any intervention which the community does not like. You know, even like example, I think pregnancy tests took a long time to come into the system, but now it's well accepted by everyone. So similarly, when you are introducing something new, or awareness should be created, and patient education is community education is very important. So health awareness would be one very important topic that needs to be taken up. I think COVID played a very wonderful role. It was an example which really set, and where people were using face masks though some of them didn't use them correctly and they were used as chin masks rather than face masks, but it was an important part.
Thank you, ma'am. I would add to that, Japanese encephalitis was controlled due to, I think, community measures. Earlier, it was a sort of a pandemic only, but then they attended it at community level, and vector prevention control was done, and then it was taken care of. So, I think we have discussed so much, but bhooke pet na bhajan gopala. So, I think nutritionist is an important component of any discussion and every discussion. So I would like to ask Dr. Tiwari, Dr. Poonam ma'am, what is the role of nutrition in patient recovery and healing? Your take on that, ma'am.
Yeah. A very good afternoon to all of you, and thank you organizers for giving this chance. From this forum, I would like to say, we are talking about patient. हम जब मरीज की बात कर रहे हैं, तो वो मरीज हम सभी के लिए अलग नहीं है, और जिस दिन हम ये समझ जाएंगे और साथ मिलके करेंगे, तो पेशेंट सेफ्टी को हम एक क्या 2-3 पेडिस्ट्रल ऊपर ले जाएंगे. आज मैं भावी डॉक्टरों के साथ बैठी हूँ, कल को हम कहीं आपसे मिलेंगे, तो हमारी कोशिश और आज के इस फोरम का मकसद ये है कि ये जो टीम आप देख रहे हैं, ये आपके क्लिनिक में, आपके सेटअप में, आपके साथ चलनी होनी चाहिए, और आपका कम्युनिकेशन मल्टी कम्युनिकेशन होते हुए पेशेंट सेफ्टी को आगे ले जाना चाहिए, जो आज मिसिंग है. तो मेरी बस ये रिक्वेस्ट है कि प्लीज हम सब मिलकर पेशेंट को अगर एक टीम की तरह देखेंगे, मैं एक एज एन इंडिविजुअल देखूंगी कि मुझे डॉक्टर लिख के चले गए कि 1800 किलो कैलोरीज देना है, बिना सोचे समझे बस मैं वो ऑर्डर फॉलो करूं, किचन से बोल दूं फीड आएगी, मैं सिस्टर से कम्युनिकेट ना करूं और अपना काम करके चली आऊं, तो शायद हम में से कोई भी पेशेंट सेफ्टी नहीं दे पाएगा, क्योंकि हम सबकी राय, हम सबका एक्सपर्टीज एक साथ मिलके आना जरूरी है. यही बात न्यूट्रिशन पे बहुत लागू होती है. जैसा सर ने कहा, क्रिटिकली इल पेशेंट. क्रिटिकली इल क्या सर? अगर हॉस्पिटल में एंट्री पे मैंने अगर ये पहचान लिया कि ये मेरा मरीज मैल नरिश्ड है और उसकी सर्जरी या किसी चीज के पहले मैंने उसका न्यूट्रिशनल स्टेटस ऑप्टिमम कर दिया, तो शायद मैं उसके कई सारे बर्डन्स कम कर दूंगी. इकोनॉमिकल बर्डन, लेंथ ऑफ स्टे, morbidity, mortality, and whatnot. So nutrition is a therapeutic pillar nowadays. It is a preventive medicine. A vast has been done and vast need to be acknowledged and recognized. So अगर हम critically ill patients की बात करें ICU में, तो हमें बहुत कुछ जो ध्यान देना है वो micronutrients and protein. That is something which really works out. Wean off patient from ventilators. So that is somewhere where we need to discuss. My takeaway is, whenever your doctor says or they plan something, do come up, do speak with them, tell them कि सर अभी हम बहुत excited होके 1800 किलो कैलोरीज नहीं करेंगे सर, patient hyper osmolarity में चला जाएगा. Discuss. Tell your sister when we have to aspirate and see how we can help us out. Sister, my nurse can let me know that madam आपने ये feed भेजी थी, patient को बहुत diarrhea हो रहा है, please come up and see. This is how we work. So if in a critically set, if I have to look, immunonutrients are very important. We really need to work with zinc, magnesium, vitamin C, other antioxidants, because they are very, very important for a critically ill patient. Protein, as I told you, do not worry. 1.2, 0.8 अभी ICMR ने normals के लिए बोला है, but in critically ill patient 1.5, 2 is also okay. But it has to be gradual. As a team approach, a nutritional prescription or a medical nutrition therapy can be of a great help and can reduce your patient's stay. You could be a very well-known clinician the moment you have a good team working with you. So that's my say. Thank you.
So, the crux is that inter-professional collaboration can turn policies into outcome. So we have to work on that. So coming to the next phase of the discussion, again I will share a small story. During COVID times, we had all sorts of policies, medication की policy, how to give physiotherapy की सब कुछ सारा set. मगर one fine day we had a patient जो 5वें floor पर चढ़ गया and he was about to jump. He was so frustrated with he was claustrophobic. So now at that time we didn't had any policy which was addressing the psychiatric issues, which was addressing the mental health, and this is the upcoming thing. Mental health is not only for patients, it is for us, for students, for postgraduates, for faculty. Everyone is going through that. So I would like to know your take on mental health and how to prevent hospital related injuries, taking that into account. I will start with Dr. Amrita. Yeah.
Yes, I think mental health is one very important aspect which we all need to deal with, and with the current, especially I think even for the younger generation, because of the COVID times, actually all of us, because though the healthcare people were all working, most of the younger generation unfortunately were at home, and with the online schooling they were really affected by it. The online schooling moved on to an excess screen time, and somehow the interaction and social interaction has really diminished in the families also, because they don't talk with each other. So it's very important that we learn communication, ensure that you spend time with your family, as a unit, to sit together, to have at least one meal together. I think these are very important aspects which will, small changes if you make and you adjust at your home, will definitely play a larger role when you move on to a larger community. And you have to be out of your devices, which even I tell my children also, that you have to move out, you have to go out and play, you have to interact. I think these are things, and also understanding, it's important that as an individual you understand that something is wrong. If you are feeling something like we're talking about depression, anxiety, it's important for you to understand that, and without any hesitancy to approach the right person. So it is in that flexibility and that stigma around having any mental illness should slowly, I think over a period of time, we need to overcome it and realize that this is an important and a rising problem that is going to affect most of us, and we really need to work on this, creating awareness and to having even youth-friendly services or adolescent-friendly clinics is important, where you have a counselor in place, and not to have something where confidentiality and privacy is maintained, because all of them feel that someone is watching them and they don't approach. So having it at a place where it is easily acceptable would be really important. And for everyone, even the adults also need to really be open about it.
Sometimes I feel that I need a psychiatric counseling by end of the day, because we are so as primary contact, I think nurses are the primary contact, and they are the first to identify the patient with mental health. So ma'am, your take on that?
Before I answer that question, related to that, I would like to say that nurses are working in an environment, and unless all of us, not only nurses, but those who are working in the environment, they have to first feel safe and mentally healthy. You know, mental health is a very special topic to my heart, because that's my specialty. And it is not, as Dr. Siddharth rightly just stated, it is not, before the psychiatric unit used to be outside, there was no integrated approach. But now we see that now in our hospital also we have a ward which is with other wards also. That is very good step. So we all need mental health. So unless the people who are working, and unless we who want to give patient, we want to promote patient safety, unless we are mentally healthy, I don't think that no matter what we do, we can make that environment safe for our patients. So first of all, in order to identify other people's, or our patient safety or mental safety or psychological safety that we are talking about, we have to ensure that the nurses who are working, and others too, whether they are really mentally healthy. And to find out that, I think it's the major thing of the superiors or the the people in administration, to see what services do we have for them. Like for example, I would see, The supervisor comes to the ward and he or she sees the nurse sitting in the ward. Immediately what happens is he will say or she will say, okay, come to my office. There is a letter which is issued to her without even asking why she was sitting. Maybe she had some physical, she had some problem, or whether she had a bad day, but just issuing a letter to her, she is not going to be mentally safe. So we need to first, address to those things, the students, same thing with the students, why student is sitting, or why she is not at the bedside. So finding out that is very important, and in our university, I think I always say that we have a lot of resources to do that. We have counseling departments, we have happiness department for students in the university, but how many of them are approaching us? So that is one thing. And coming to, I'll tell you one story, and it's a real story. A patient who was 71 years old, he had a stroke and had hemiplegia, and he was in the hospital. One day, he was in a very busy unit, and one day his son comes to visit him, and he sees that his father is on the wheelchair and half lying, almost like hanging. And the food that he was probably eating, the spoon is on the floor, and the food is just dripping, from his mouth. The son started crying, seeing the father. Once upon a time, father was such a figure, more than the son, the father started to cry. Father started to cry, and he scribbled. He couldn't speak, so he scribbled saying that, I'm very unfortunate that you, my son, is seeing me. So he had this sense of, feeling so shameful that I'm so vulnerable, and nurses were going up and down there, and they were so busy doing so many good things that they did not see this patient on the thing. Physical safety, yes, I see that. Patient might have fallen down and had injury, but see the psychological trauma that the patient is going through. The patient can't speak, can't communicate, patient can't get up off the wheelchair, but he is going through so much. So this is everyday thing that is happening. And the question that Dr. Siddharth had asked me, how to identify? Then whichever ward we are in, whether we are in medical ward, surgical ward, gynae ward, any ward, we should not think that mental health is a separate unit. It has to be incorporated in because we all have, emotions, whether we are in whichever ward. So we have to identify. So the early signs are patient will stop talking, patient will even refuse to eat, So these are the early signs that we can say, see in patients. Patient will not sleep, will have sleepless night, will even ask, kya mujhe kuch dawai mil jayegi sone ke liye? So you can identify that something is going on in patient's mind, and he may need a consultation. So again, there is integrating. If anybody, any ward or any specialty, our nurses play a wide role in that, because we are watching the patient, and we should be able to report to the doctors when they come for rounds that patient is going through this. Not only for the part that he's come for the surgery, but also this aspect. And also doctors should take note when the nurse is reporting. Dr. Vasunkar very well has said that nurses need to be have empowerment and given empowerment. It is both give and take. Nurses should do their duties in such a way that people respect them, I always say, and that is gaining empowerment. But at the same time, there are times when nurses have suggested, and the doctor's comment was, "Aapka jo kaam hai wo aap kariye, ab hame mat sikhaiye." I think we are not going anywhere with integration here. Interprofessional. Dr. Anuja is so much passionate about it, but so that's one step we have to move ahead. So if the nurse is saying something, I think it should be. Otherwise, you are suppressing them, and one day they are going to be mum, and just like a mechanical, वो जो movie में दिखाया जाता है, ट्रे लेकर नर्स खड़ी है डॉक्टर के पीछे, and that is what going to happen, and that is happening also in some places. So it has to be both ways, and we have to respect each other, as ma'am also said rightly, that we have to come together to do. So psychological well-being is important no matter where our patient is, and psychological well-being is also important for all of us here, whether we are doctors or nurses or physiotherapist or nutritionist, anybody, we all need it. So self-care and then care for others. So self-care is very, very important for all of us. Unless we take care of ourselves, we cannot give care to others. Thank you.
Don't worry, ma'am. We'll work on that. So, Dr. Poonam, ma'am, your take on can we identify this with eating behaviors, the mental health of a patient?
Yeah.
Or
Okay. Very well said. खाना एक ऐसी चीज है जिसके साथ सारे इमोशंस जुड़े हैं. घर पे भी हम गुस्सा खाने पे दिखाते हैं और खुशी भी खाने से जताते हैं. वही चीज मेरे पेशेंट के साथ भी है. एंड वेरी टची एग्जाम्पल की मैं आज तक नहीं भूल पाई हूँ कि इंटर्नशिप के दौरान मुझे रीनल डाइट बताने के लिए मिला. पेशेंट को डायलिसिस बताई गई थी, पैसे नहीं थे, परेशान था. मुझे इससे कोई मतलब नहीं था. मैं जाके उसके सामने पोटेशियम सोडियम बोलना शुरू की. उसने मेरे सामने थाली फेंक दी. उसने कहा आप यहाँ से चले जाइए. That was the day I realized कि I am not a mechanical person to prescribe a diet. The emotion behind the food and the patient psyche is very important. जैसे ही ICU में आता है, लंबे लंबे बिल देखता है ना, और अपने घर वालों के उदास चेहरे, तो आधी चीजें तो उसकी वैसे ही खत्म हो जाती हैं. और उस चीज को समझते हुए अगर वो खा नहीं रहा है तो मेरा ध्यान इस बात पे नहीं होना चाहिए कि इतना प्रोटीन अंदर नहीं गया. मुझे उसको ये समझाना है कि बाहर आने के लिए तो ये खाना ही पड़ेगा. तो जो मेंटल हेल्थ इस तरह की मरीज की उस समय होती है, वी कैन ओनली अंडरस्टैंड इफ कहीं हम एक बार को सोचे कि इसकी जगह अगर हम होते तो. एंड आई थिंक आई कुड डू वंडर्स थिंकिंग दैट वे. एंड दैट इज व्हाट मेंटल हेल्थ precautions from every healthcare worker requires this only. एक बार उसकी जगह पे खड़े होके सोच लीजिए, आप इलाज अच्छा कर ले जाएंगे. Thank you.
Thanks for a wonderful insight, ma'am. I think the crux of the discussion is that we have to communicate. Interprofessional thing has to come in a good way and a big way. So I would request Dr. Tariq to kindly, sir, please sum up the entire thing, and then I think we can close the session.
It was a wonderful session, panel discussion, and all the members of the panel, as well as the moderator, they presented very well. Fantastic. Congratulations to all of them, and congratulations to all of the organizing committee. Patient safety is a very important part of the medical sciences, and these type of conferences must continue time to time to achieve its goal. Thank you very much.
Thank you, sir. So one thing that came across very well in this discussion was that interdisciplinary approach is required for patient safety. There's no way going around it. But the problems that exist in that interdisciplinary approach also did show up in this discussion. So we as doctors have, and here we have departments other than medical department also, but even in medical colleges or hospitals, every single department is a silo in its own. And as a DMS, on a day-to-day basis, and my earlier attrition as a DMS at the hospitals, on a day-to-day basis, I have felt that how demarcated these silos are. The points where you see these things happening is when you want to transfer a patient from one department to another. The resistance that is there to accept the patient is just basically a thought process that my silo, the patient that was admitted under me is part of my silo. Anybody who's admitted under someone else is part of their problem, not my problem. Apart from that, the resistance and the laxative attitude that I've seen in doing referencing. So these are problems that are attitudinal problems. And we have as we have seen in the part of the cognitive domain, we have taught students about what referencing is, what inter-department transfers are. At the psychomotor level, we have produced forms and checklists for the same so that they may be able to do it easily. But what we are missing is the affective domain as of yet, where they do not, where the entire hospital does not melt and become a single thing, instead of being silos in their own. So that is a problem that is happening, and that starts at the PG level itself. How many PGs go and have tea with other departments? How many times surgeons and anesthetists sit together and discuss cases and have tea together? Because in a hospital, anesthetists and surgeons who are working as part of the same team have such an antagonistic relationship. It is like surgery is a case of a surgical will and an aesthetic won't. So that is the problem that we see on an everyday basis in a hospital. Apart from that, the other issue is that in a hospital, the way doctors and other people look at their roles in a healthcare setup. So doctors, since time immemorial, have started to think that they're only knowledge providers. The entire purpose in the healthcare industry is to regurgitate the knowledge that they've accumulated over the 10 years of their training. They have forgotten that, and doctors will have to reorient that very fast now, because AI can provide knowledge better than you can. It can provide opinions better than you can to the patients. You have to realize that you are a service provider. You are providing a service to a patient. And as we did see in the skit yesterday, and this is very clear, a doctor will write a prescription, and if you ask them to explain the prescription, they will direct you to the nurse, because they do not want to talk to the patient beyond taking their symptoms, listening to the symptoms. So that is the problem. And then there is also a problem at the nursing and the other side of the healthcare. Nurses only see themselves as service providers. They do not see themselves as knowledge providers. And there's a gap, a knowledge gap also. And there is also the fact that in our hierarchical system, it's not everybody's responsibility. The patient is not everybody's responsibility. The patient is the doctor's responsibility, and the nurse's responsibility is only to translate the doctor's orders. So as long as in the American system, it is a bit different. Here, the head of the team is responsible for everything. Whatever the residents are doing, whatever the nurse is doing. In America, it is a different thing. They meld together as a part of a team, and everybody is responsible for the same patient. The head of the department is not responsible for the nurse. He is responsible for the patient. The consultant is responsible for the patient. So till we do not have this amalgamation of all the facilities that are working together in a hospital, even auxiliary facilities like housekeeping, etc., all of them have a very important role to play in the patient safety, and those errors not happening. For example, I'm from a lab care department. I'm a biochemist, and as of now, 60 to 70% of all errors that happen in a lab are pre-diagnostic, pre-analytical errors. So they are happening at the collection level or at the ward level. Most of them are mislabeled samples. The sample is labeled by someone else in someone else's name, and it has been taken from someone else. So these kind of errors, why are they happening? Because I have never sat with the nursing superintendent and talked to them what protocols should be there as far as collection of samples are concerned. So till we do not have an integrated approach, these problems will keep on cropping up. So I would once again like to thank the entire panel for a very, very interesting discussion, a very thought-provoking discussion, and Dr. Chandel for leading this discussion. Thank you very much.
Thank you very much for a wonderful discussion. Really, this panel has done a very wonderful job. But I would like to add one thing from my personal experience of so many years. Why we are not able to build up good teamwork? There is only one, ego. जब तक ईगो नहीं जाएगा, हम अच्छी टीम नहीं बना सकते. मुझे ये कहने में बिल्कुल भी कोई शर्म नहीं है कि मुझे इंजेक्शन लगाना एक नर्स ने सिखाया है बलरामपुर हॉस्पिटल में ड्यूरिंग इंटर्नशिप, बोथ आईवी एंड इंटरमस्कुलर. और मुझे कैथेटर डालना एक वार्ड बॉय ने, एक स्वीपर ने सिखाया है. मुझे बैंडेज करना ड्यूरिंग इंटर्नशिप एक वार्ड बॉय ने सिखाया है. सो यू शुड नॉट, ईगो अपना आपको छोड़ना पड़ेगा. देन ओनली यू कैन, तब आप अपने कलीग से साथ भी अच्छा कर सकते हैं. तो एवरीबॉडी हैव टू, चाहे आप किस लेवल पे हो, ईगो आपको छोड़ना पड़ेगा. मेरे ऑफिस में एज प्रिंसिपल हियर इन एरा, जब भी कोई आता है, चाहे पीजी आता है या कोई एम्प्लॉय आता है अपनी प्रॉब्लम लेके, फर्स्ट ऑफ ऑल आई से प्लीज सिट डाउन. खड़े खड़े बात नहीं है, नहीं सर नहीं, बैठो बैठो, बैठ के बात करो. जहां मैंने उसको बैठाया वो कंफर्टेबल हो गया. 50% ऑफ द प्रॉब्लम इज गॉन. खड़े खड़े बात नहीं करते हैं, बैठ के बैठाते हैं. सो वी ऑल ऑफ अस शुड डू अवे विद अवर ईगो. जब तक हम ईगो नहीं छोड़ेंगे, टीम वर्क बनाना बहुत मुश्किल होगा. इट इज अ डिफिकल्ट थिंग. Thank you very much for the nice presentation.
Thank you so much, Jamal sir, for such an important message. So once again, thank you to esteemed chairpersons, moderator and distinguished panelists for enriching this discussion with their valuable expertise and perspectives. We now move to the felicitation ceremony. I now request our respected chairpersons to kindly felicitate our esteemed panelists for their enriching deliberations. May I request Dr. Amrita Rao to kindly come forward for her felicitation. I now request Dr. Ridhan Bynes to kindly come forward for a felicitation. Next, I request Dr. Poonam Tawari to kindly come forward. May I humbly request Dr. Priscilla Samson, ma'am, to kindly come forward. I request Dr. Zia Abbas, sir, to kindly come forward for his felicitation. Now I request the chairpersons to kindly felicitate a moderator, Dr. Siddharth Chandel, for his exemplary moderation of the panel discussion. Thank you so much, respected chairpersons, for your time and presence. Now I humbly request Honorable Pro Vice Chancellor ma'am to kindly felicitate the chairpersons for this session. I request Dr. M.M. Khan sir to kindly come forward and receive his felicitation. I now request Professor Tariq Mahmood sir to kindly come forward for his felicitation. Thank you, ma'am, for doing the honors. Now, as we move to the closing ceremony of this beautiful conclave, I request Dr. Sucheta Dandekar, ma'am, to kindly come forward and conclude the ceremony on a gracious and inspiring note.
Thank you so much. What a wonderful 1.5 days this has been, the Patient Safety Conclave. And I hope all of you also enjoyed being a part of it as much as we have putting it all together. So, as we come to the close, it is both a privilege and a responsibility to reflect on what these 2 days have truly given us. Across sessions, case discussions, and conversations, one message has come through very clearly. Patient safety is not about individual perfection, but about strong systems, shared accountability, and a culture that allows us to learn from error rather than hide it. We explored how interdisciplinary teamwork, effective communication, and reporting frameworks can transform near misses into powerful learning opportunities. The case-based discussions reinforced
that when we look at errors, honestly and collectively, they become catalysts for safer care. Most importantly, this conclave has called each of us to commitment to speak up when something feels unsafe. What has been particularly encouraging for me has been the active participation from multiple professions. Clinicians, nurses, educators, administrators, and all of you, my dear students, all contributing their perspectives. This truly reflects the kind of multi-professional culture of safety that we aspire to build, not only in theory, but in daily practice. In this context, Era University's vision has been clearly reflected throughout this conclave. And as we conclude, I invite each one of us to make a personal commitment to speak up when something feels unsafe, to report and learn without fear. A special word of appreciation to the organizing team, volunteers, my dear students, whose behind-the-scenes efforts have made this conclave run so smoothly. You will see the students and the transport committee has been at it day in and day out. I would be failing in my duty if I did not mention the IT department, Sandeep, and his TV, 𝐂𝐚𝐭𝐲𝐿, who have been instrumental in putting this together, not only what you are seeing here today, but having the Zoom link so perfectly, and I'm sure you can see up there, we have a lot of people, participants, who are watching us and listening to us across India. And I would like to specially mention the Academy of Health Professions Educators, who are all here with us. And I would also encourage all of you to become members of the AHPE so that all of us, as a complete community, can build a community of practice here together. And therefore, thank you so much. Let us shift the narrative, therefore, from merely preventing harm to actively promoting patient comfort, confidence, and dignity as the true markers of quality care. Thank you very much. I wish you all a safe journey home. And those of you who are here from Lucknow, we invite you to remember that patient comes first. And those of you from Lucknow also, have a good weekend. And thank you for being with us. Lunch is served in the main ground. Yes, so please be with us. Thank you.